All right. Thank you for giving me the floor. My name is Bengt van Loosdrecht. I am the Dutch ambassador since last August to Sweden. I think the timing of these meetings is really good, as there is increasing pressure on healthcare systems in the world, in Europe, of course, and we have a way now together to look at ways to ease that pressure. So thank you for bringing together all these parties. Actually, the Netherlands, Switzerland, and Forum for Healthcare is organizing this. It's good to bring together those parties who deal with health policy and especially now with healthcare. The goal of the webinars is to learn from each other, to look at best practices with a view to not reinventing the wheel, as we can learn a lot from each other's experiences. This embassy has helped to bring together parties in the past, those parties who otherwise maybe wouldn't have met so quickly. I would like to commend and thank the Embassy of Switzerland for participating and Forum for Health Policy, as they're called, for their very active role. From the Netherlands point of view, as I want to talk substance, I would like to raise a few points. The one is on what we call the Dutch Task Force for Healthcare. That's a platform in the Netherlands that deals with life sciences and health sector support. They support about 100 Dutch companies, NGOs, and knowledge institutions, healthcare providers, and governments, and they want to realize and strengthen their international ambitions, don't we all? More concretely, the partners provide innovative and sustainable solutions to healthcare challenges, and they are active all over the world. They want to broaden and strengthen their network, and the task force in the Netherlands is the first point of call for anyone who seeks Dutch life sciences and health expertise. With our approach, we want to improve the healthcare by connecting the right people. So, as a recommendation to you, do not hesitate to connect with the Task Force Healthcare, as we call it, and if needed, you can connect with them through this embassy. Then I have a few points that come through the Ministry of Health from the Netherlands. The Ministry of Health has conducted a large study on capacity development and innovation in elderly care. And I will make a few provocative propositions here. The study that was conducted in the Netherlands has found that innovation will not help significantly to relieve the pressure on health services by a growing aging population. So there is no real correlation between innovation and the help to the aging patients. The bottom line is we need humans to do the work. So I will pose a question here, and the question is, does innovation really help when what we really need is human resources? The second point is, in the Netherlands, care is being given a lot by friends and family to patients. We call it mantelzorg. That's impossible to translate, but I guess the Dutch participants will know a good word for that. Anyway, this system of help by friends and family is facing increasing pressure as the people giving care are getting older as well. So as a result, there is a tension between an increasing group of patients, because they get older, who receive care by a decreasing group of caregivers. As they get older, the group also decreases, or they become patients. So I'd like to contradict my first proposition now and say or ask, can innovation help to alleviate the dwindling number of caregivers? Can innovation do something about the number of caregivers that is declining? And then lastly, the COVID epidemic or pandemic has disrupted all the ways that we communicate. This is nothing new to you, but there's a dramatic shift from offline to online. Appointments, meetings, conversations, and orders are increasingly done online. So the final question here is, the crisis has given us new ways to remain engaged. And as a result, innovation will give us prospects for better contacts with caregivers and with non-traditional caregivers. If it is well designed, could innovation not help to improve the quality of life? These are my introductory remarks. Thank you very much for inviting me, and I wish you all a good seminar. Thank you.
Thank you very much, Bengt. Then I take the word here, if I may. My name is Claudia Fontana Tobiasen. I'm the Chargé d'Affaires ad interim at the Embassy of Switzerland in Stockholm. The Embassy of Switzerland is happy to co-organize this event on innovation in elderly care. Switzerland has a long tradition of strong global pharmaceutical and medtech companies. In fact, two of the five largest global actors in this sector, Novartis and Roche, are Swiss. The strong life science tradition in Basel, the home base for these two companies, combined with the world-renowned universities and research institutes, the ETH in Zurich and the EPFL in Lausanne, has spawned several innovative startups in health tech, bioinformatics, and health services, one of which will participate in today's discussion. This is the third time that the Swiss Embassy organizes a joint event with the Embassy of the Netherlands and the Forum for Health Policy in partnership with both countries' chambers of commerce, Switzerland Global Enterprise, and Walker Project Scandinavia. The first event, held in September 2017, focused on the quality of the three countries' healthcare systems, which all rank among the top 10 in the world, and did an in-depth comparison between the systems, which vary from the Swedish almost fully publicly financed model to the Netherlands system, which is fully based on health insurances offered by private insurance companies. The second seminar, held in March 2018, took a view on innovation in healthcare, as seen from the policymaker's perspective, as well as the entrepreneurial perspective. What is the future of healthcare? What hinders do organizations pose? And what barriers do healthcare entrepreneurs face? What can we learn from each other? And how can we speed up innovation for the benefit of all? Today's seminar focuses on the issues facing the elderly care. While the problems have been accentuated by the corona pandemic, the underlying challenges stem from an ever inverting population pyramid of the industrialized countries. In a series of reports last year, the think tank Timbro illuminated some of the differences in the elderly care systems that the Netherlands and Switzerland offer compared to Sweden. We hope to illuminate these differences further, once again in the spirit of what common challenges do we share and what can we learn from one another. I would like to thank all involved in the realization of this event for their contribution and all the viewers for participating. Welcome and thank you.
So I will also welcome everybody. My name is Peter Graf and I'm chairman of the Forum for Health Policy. And as we heard, we have had a lot of collaboration and good workshops previously with the Netherlands and with Switzerland. And I would really thank you for the nice collaboration that we have. And today I will welcome everybody to talk about this very important topic about innovation in elderly care. And we heard Bengt asking us good questions. How can innovation or can innovation really improve the situation and looking forward with this big challenge globally really. And the corona pandemic COVID situation has of course increased the necessity of better collaboration between healthcare and elderly care. I will also take the opportunity to say that Forum for Health Policy is a think tank, independent think tank in Sweden. We want to improve healthcare, make it more efficient, things like that. And today we also publish a report, Innovation in Elderly Care, by one of our co-workers, a student from the Karolinska Institute, Nishi Dave. Very nice report. We will bring it to you, and it's good reading to look into that. when I'm not the chairman on the forum, I work. I'm the CEO of an integrated healthcare system in Norrtälje. It's the northern parts of region, the Stockholm region, where we have integrated the healthcare system really. So we have hospital, elderly homes, psychiatry, everything, home care, everything within the same organization. And my viewpoint, and I know that a lot of people in Sweden are now debating and discussing how can we make the collaboration and the interaction between the healthcare system, primary care, hospitals, and the elderly homes better and more integrated. In Sweden and the Stockholm region this spring, we had big problems. I think you all know that, with a lot of deaths in our elderly homes. And one of the issues was that the medical, the doctor participation and the nursing participation in the elderly homes, because it's divided between the municipality care side and the hospitals and the primary care where the doctors and the nurses are. We have to link it more together. And in my company, when we have everything integrated, we had much quicker and we had a better situation actually to make this integration and also prevented deaths actually. So we had much less deaths in our situation than in many other areas in the Stockholm area. And I think it illustrates we have to work more closely now going forward. We can now see that the corona situation is increasing in Europe and globally, and we have to, I think, meet better, make it more efficient. Bengt's question, I think, was very good, and I hope we get back to it. Our sort of what we have learned from this spring was also we have all these things we want to connect from the home care to the hospitals and make digital. The blood pressure, things like that. We want to see it online, but frankly, at least in our setting, when we try to do that with these fancy solutions, we have big technical problems. We can see we have big. So the issue about actually going there, listen to the heart and things like that, bedside in people's homes. We still do that because we find that the technical side is lacking, and I would like to address that topic to all of you. How can we make it more sustainable? How can we make it better? Wi-Fi and things like that, and also directly into the charts. Things like that has to, I think, improve to make it even more effective, better. Things like that. So I will stop here and just welcome you all to this interesting afternoon. So I give the word now to Katarina Backman, who is the head of the think tank Forum for Health Policy. Please, Katarina.
Thank you so much, Peter, and thank you, Bengt and Claudia. I'm so happy to have you all online here for this interesting workshop, Innovation in Elderly Care. My name is Katarina Barkman, and I'm head of Forum for Health Policy. And I'm a former director of innovation from the region of Stockholm. And this international workshop with a lot of expertise will give us some glimpses of different angles on innovation. And we have very good, interesting speakers, and we have also very qualified members in our panel discussion. But I will start with some practical issues. We have, you can comment or ask questions on Menti. You will see the code. You're supposed to see the code below, 2294355. You will be able to see the number. Please comment, give some questions that we will also convey to the speakers. We also have #innovation, #elderly care. So please comment on the speakers on this workshop that we are doing now. So of course, this is an afternoon where we won't be able to cover the whole field of this broad spectrum of innovation, but we will talk a bit about ownership, privatization with Henrik Jordahl. We will talk about technical solutions with Andrew Pace. Henk Nies is going to talk about the quality paradigm. Karin Thalén, CEO from Stockholm Sjukhem Hospital in Stockholm, will also comment on innovation on the floor in the hospital. So Magnus Lejelöw, you're also a member of the board of Forum for Health Policy. Welcome on board. How do you feel?
I feel good. I'm really excited about this and excited about the opportunity of co-moderating this together with you, Katarina. I will be responsible for guiding you, the speakers, with questions. So using Menti, so hopefully you can help me a lot with a lot of good questions. And we'll kick off just to get to know the bunch that's out there. So we'll start with using Menti just to see, okay, where are you from? Is it Uppsala, Örebro, or the Netherlands? Just to get to know you. So use the code 2294355 and answer at menti.com.
Yeah, great. So let us start with Henrik Jordahl. You're so welcome. You're a professor of economics at Örebro University. You're also affiliated to the Research Institute of Industrial Economics. But most importantly, you're also a member of Forum for Health Policy's Research Network. And you have done a lot of research on different organizational forms. You have done research on choice between public and private production and so on. And the ownership question, what does it matter when it comes to efficiency, quality, and perhaps innovation? So please, Henrik, you're most welcome, and I will give the word to you.
Thank you, Katarina. Okay, and thanks a lot for inviting me, and thanks for all of your online attention. So I will try to shed some light on privatization and choice, with the combination of which has been a really important development in Sweden for the last 3 decades. So this is not about innovation specifically, but privatization and choice are sort of underlying forces that can both drive innovation. And just as a short background, so this is a workshop co-organized by Sweden, Netherlands, and Switzerland. So there are about 1.2 million people in the Netherlands older than 80 years, about 800,000 people in Sweden, and 700,000 people in the Switzerland. And importantly, the group of people above 80 is growing. So in Sweden, it's predicted that this group will increase by 50% in the next 10 years. So Sweden will be in 10 years about where the Netherlands are today when it comes to the number of old people. And this is relevant here since about half of the people in this age group need elderly care in some form. And so here I have a bar chart of long-term care expenditure as a share of GDP. And what is included is government spending and spending in compulsory private insurance systems. And the Netherlands, as you may know, is the top spender in the world when it comes to long-term care. Sweden is close to that, 3.2% of GDP, 3.7% in the Netherlands. And Switzerland is about around the OECD average. But all three countries spend substantial resources on long-term care. And also, I mean, it's difficult to make cross-country comparisons of the quality and satisfaction of elderly care, but in all of the three countries, judging from available studies, old people are comparatively satisfied with life, internationally speaking. And so my topic today is privatization and choice. And I would like to use Sweden as a natural experiment here. Sweden is a country with really ambitious social goals and with a lot of tax-financed services, not only in elderly care, but also in healthcare, in education, in preschools, in care for disabled people, and so on. So, particular to Sweden is that almost all elderly care is tax-financed. There is some privately financed care at the margin, but when I talk about the tax-financed part of it, which I will do here, it's really almost all of it. Apart from informal care, of course. And then Sweden is special since around the 1990s. Well, Sweden was special before that in that everything in the elderly care sector was handled by the public sector, by the municipalities and the regions. And since the 1990s, there has been a steady development with increasing privatization, increasing choice for users. And also an interesting aspect of this is that almost all of the new providers have been for-profit companies. There are also non-profits here, but they are really small compared with the for-profit providers. And I mean, so this has been a sort of controversial topic in Sweden where some people embrace it, some people are really hostile towards it. But it has been difficult to evaluate this. So only recently there has been a wave of scientific studies and policy reports, so that it's much easier since a couple of years back to take stock of the evidence and evaluate this development. And so much of my talk here is based on a book forthcoming now in December with my colleague Morten Blix, Privatizing Welfare Services, Lessons from the Swedish Experiment. And so here we make such an evaluation of privatization in Swedish tax finance services, so including elderly care, but also the other parts of the Swedish welfare sector. And so elderly care mainly consists of home care services and nursing homes. There is also some short-term housing, but that's a really marginal part of the costs. And so here is the development of the private production shares in home care services and in nursing homes. The graphs begin in 1999, but the privatization really started off in 1989 in Sweden in the municipality of Danderyd, a wealthy suburb to Stockholm. So before that, everything was carried out by the municipalities. But then after some experimentation and also legal battles, Danderyd managed to contract out home care to a private company. And it is the private company that has since then developed into Attendo. And then we had a sort of slow but steady increase in the private production shares. And in 2009, there was an important reform, the freedom of choice reform in English, or lagen om valfrihetssystem in Swedish. And this act confirmed that the municipalities, they do have the right to establish free choice systems. Many of them had done so by themselves already before that. And the act prescribed that such systems have to meet specific national standards for information, for market entry, and for choice. And looking at the development of private production, we can see also at a finer level than this graph that the free choice systems have increased privatization. So you get faster privatization with the free choice systems compared with privatization, compared with municipalities that use more procurement style elderly care. And yes. And so Danderyd showed the way, and the municipality was followed by a few other municipalities. This was mainly in and around Stockholm. And so interestingly, over time, we see a pattern of policy or privatization diffusion. So municipalities of different political color and economic situation have followed their neighbors. So you're much more likely as a municipality to try out private elderly care if a neighboring municipality has already done so. So we have seen clusters of privatization in Sweden, and I hope this will be demonstrated by clicking through the years. So you can see that the new privatizations happen close to the municipalities where it had already taken place. And so this was for elderly care. This was share of private employment in the elderly care sector. And this is different from other tax financed welfare services, that here privatization in elderly care was for local development. And as I mentioned, the 2009 freedom of choice reform mostly confirmed the development that had already happened in many municipalities. So this has been sort of an organic development, privatization from below. And there are important regional differences. As you can see, this is almost about 40% of elderly care is in private hands in municipalities close to the major cities, whereas in countryside municipalities, private providers are still a marginal phenomenon, below 5%, both in nursing home and in home care services. And so evaluating this is tricky. As I said, most of the research has been in recent years. So elderly care then is an example of a so-called quasi-market, which means that you have both public and private providers competing for business and paid for by tax money. So the end users themselves do not pay for the services here within this Swedish system. As has been pointed out by economists, but also very often in the policy debate, quasi-markets come with a lot of potential problems. So there is asymmetric information, there are problems of incomplete contracts. Switching costs can be high. And in particular, quality is really difficult to measure, and that's sort of the main reason for contracts always being highly incomplete. Then, on the other hand, privatization was a response when it initially happened. I started in '89, but also in the 90s. It was a response to dissatisfaction with an unresponsive public sector at that time. So elderly care, but also healthcare, education, there was this sort of one-size-fits-all solution where you couldn't sort of cater to minority preferences or develop your own method of delivery if you wanted to. And so comparing the private and public alternative, one should really avoid, and this is not at all always avoided, the so-called nirvana fallacy. And you often hear people comparing an ideal state with a realistic alternative. So for instance, you say that, okay, we have this existing private sector with all flaws of the market. And then we compare that with an ideal, flawless public sector solution. Of course, that's an invalid argument, sort of. It's a form of a false comparison, but you hear that a lot. Alternatively, you could compare a market with perfect competition with the existing public sector, which is sort of also obviously a false comparison. And I'm an economist, and among economists, you often hear, also from teachers lecturing students and so on, that there are so-called market failures. And sort of that's a sufficient argument for political intervention. Of course, that's not really the case, because you can always have support for some theoretical argument that there is a problem on the market. And there will always be potential public sector interventions to deal with that. And the ultimate challenge is to evaluate or compare the existing public and private solutions empirically and find the dominant effects. And this is what so Morten Blix and I have done when compiling all of the recent research in our forthcoming book. And as an economist, I need to start with the costs. And here, what we can see is that the public providers seem to have slightly higher costs and therefore make losses in many municipalities. This is in home care. So an interesting feature with the freedom of choice system in home care is that the public and private providers should compete on an equal footing and be part of the same remuneration system. So the payment to private providers should equal the costs of the public providers. And so in such a system, you see whether the public providers are able to make to produce elderly care at the same costs as they pay to the private providers for the exact same 1 hour of service, say. And in many municipalities, we have seen that they are not able to deliver this service at the same cost. So there is a deficit that has to be covered by the end of the year. So private providers seem to have an advantage. Another important aspect is that it's, at least initially, with choice systems, there is a high risk of an increase in total costs. because it's really difficult to ration and limit the delivered service within the choice system. So previously, when everything was conducted within the public sector, it didn't matter as much how many hours of home care a particular user was entitled to. So that was not really binding, because sort of middle management in home care could always go in and ration the service if costs started to increase too fast. Now it's different, and in particular with the private companies. So if a care manager has decided that you are entitled to, say, 20 hours of home care every week, there is really no incentive for you, of course, as an elderly person or as your private provider to deliver less than that. And therefore, there is a sort of risk that costs will increase faster within a choice system. Of course, it's good that people get the services that they are entitled to. I'm not saying that, but we need to pay attention to the costs more than we did before, perhaps, when this sort of took care of itself within the public sector, although in a really opaque way. User satisfaction is, of course, important when evaluating different alternatives. Here, there has been a couple of comparisons, and we don't see any difference between private and public providers really when it comes to the satisfaction of the users at the national level. Stockholm is a possible exception, but it's an older study. But it could be the case that Stockholm, with the largest market, also largest private market, that the private providers have a bit more satisfied users, both in nursing home and in home care, than the public providers. So looking at the freedom of choice reform, this reform was introduced sequentially in the municipalities, which is an important feature because you can then more easily evaluate the consequences of the reform compared if you have a one-off reform nationally. And here we see that user satisfaction picks up slightly after a municipality has implemented the freedom of choice reform. So that's positive. And it's particularly positive since if we ask elderly people, it's really the case that choice opportunities are appreciated. That's sort of one thing that everybody agrees on, that they really value and appreciate the ability to make a choice, and if they are dissatisfied, to make a switch. The problem with user satisfaction is that it gives only a part of the picture. So maybe in home care, you can say that, so what you see is what you get, and there is not much more to home care quality than the satisfaction of the users. I would at least be willing to say that you get almost a complete quality picture by asking the users. With even older people in nursing home, it's more difficult because the healthcare component is more important. You might be satisfied with services in a nursing home, even if all of your medical needs have not been given proper attention, because it's really important to evaluate medical services as a consumer. And it's also the case, of course, that the quality of healthcare becomes fully apparent only later on. So we need other quality measures to complement the picture of user choice, and especially in nursing homes. And going to objective quality measures, there is a big debate what are appropriate objective quality measures in elderly care, but we have looked at some of the established one that Swedish authorities publish and collect and publish. And here we see that if we look at structural quality indicators, that is the employees, the buildings, the resources, public nursing homes tend to score better on those quality indicators. And this is in particular for staffing. So there are more employees per elderly people in public nursing homes than in private nursing homes. Whereas private nursing homes really do better on process quality indicators, such as the medication reviews. And this difference is clearer, it's more marked compared with the difference on structural quality indicators. One reason might be that there has been some financial bonuses to providers who, for instance, perform medication reviews and similar reviews. And here, so it could just be that private companies are more sensitive to financial bonuses than public organizations are. And there has also been, there is a paper comparing nursing homes of different private ownerships types. So for profit nursing homes, non-profit ones, and there is really no difference there. You can also compare nursing homes run by so-called private equity companies with other private companies. There is also no quality difference, it seems, between those groups. And also with respect to profitability, which has been a big debate in Sweden. There was for many years a suggestion to cap profits in the private welfare sector. And so I have compared the quality indicators of nursing homes with respect to the profitability levels of the companies running them. And there are overall no quality differences between more and less profitable nursing homes here. If anything, a few indicators indicated higher quality in nursing homes run by more profitable companies. And an important study looking at the introduction of private nursing homes. So what happens after a municipality starts to or lets in the first private nursing home to operate in the municipality. And this has led to a clear improvement in productivity. So after the first privatization in a municipality, there has been a reduction in costs, but also a reduction in mortality among old people in this municipality. So here, especially with, I mean, mortality is important, of course, as such. It's sort of the ultimate thing that we would like to avoid. And it's also sort of, you get a lot of critique sometimes about private companies cutting corners and just sort of shirking on quality. So mortality is a measure that you cannot really shirk on, because if you don't miss in public register that people die. So if we observe mortality in a municipality, we have a really good overall measure about healthcare quality for the oldest people. So to conclude, Privatization and choice have led to some improvements, that's clear, but it's also the case that challenges remain. Gatekeepers are needed. I mentioned the risk for spiraling costs, and it's also that municipalities really need to separate their role as at the system and provider levels. And this is because of the public loss making that I mentioned, that there is this risk that since the municipality, unlike private companies, can run deficits, they will be more willing to do so. So it's important that the same rules with regard to budgets apply for both public and private providers. And finally, rules must allow for private companies to introduce new technologies, also for them to introduce existing technologies that are often not adapted that rapidly into healthcare, elderly care. So here it's when designing payment systems, choice systems. I mean, regulation is important, but there is a risk that regulation becomes a drag in that innovation is delayed. Thanks a lot.
Thank you so much, Henrik. Very interesting presentation, and we should remind our international viewers that this comparison between public and private providers, it's under the umbrella, as Henrik said, tax financed healthcare, health service, welfare service. So I think it's very interesting, Henrik, that this is in real life experiment, which we seldom do when it comes to developing organization. And that's also something which could be used when trying to implement new developments and new innovation. I also think it's very interesting that you were also focusing on costs, which we seldom do. We talk too little about output and costs, because we also have more room for innovation, of course, if you have an efficient organization. So thank you very much, Henrik, and I think it's very applicable when you talk about innovation. You have to have an efficient organization, and where one aspect is, of course, the ownership. Does it matter when it comes to cost, when it comes to quality, and also innovation opportunities? I know, Magnus, that we do have some Menti questions for Henrik, right?
Absolutely. First of all, it's great to see that you are using Menti so that we get a lot of good questions. There are some about costs and some about efficiency as well. So I will start off, Henrik, with what are relevant factors for differences in user satisfaction? Did your research show something regarding this question?
The relevant factor for user satisfaction?
Yes. Kind of an important one for the elderly, I guess.
Yes. I don't remember exactly now, so we used the overall user satisfaction when making this comparison. Of course, that can be divided into certain subcomponents, and I have to admit I don't remember exactly which components that drive user satisfaction. So as I mentioned from our research, it's the ability to make a choice is important, but I don't want to say anything in particular on the details of the services. No.
No worries. You will get that question answered on Twitter later, I guess, then.
Okay.
I take another one. Did quality of life indicators for residents increase in private-owned nursing homes?
Can you repeat that,
Did quality of life indicators for residents increase in private-owned nursing homes?
I don't know that either, I have to admit. So we had this it's an increase in user satisfaction, and it's an increase in those objective quality measures. No, I don't know that either. I don't think that was covered in that research actually. So it's a good question that sort of remains to be answered.
Yeah, but it's good to see that there is. I mean, you raised a lot of questions, and that's always the important thing with having a good talk. I know that we need to move forward, Katarina. So I will just remind everybody of Menti and the code 2294355 is the way of reaching the question box. So please keep on using that. And thank you, Henrik.
Thank you.
Thank you so much, Magnus and Henrik. And I will also remind you that after the workshop, we will put some nice documentation on our website. And I'm sure you can contact Henrik for more information or questions or discussions to your important study. So let's move on to Henk Nies. You're very welcome, Henk. So happy to have you on board. And you are director at VLANS, the National Center of Expertise for Long-Term Care. And you're also professor of organization and policy in long-term care at Vrije University, Amsterdam. And you will talk a bit about when it comes to quality paradigm in elderly care, as we call new elderly care, and some aspects of that. So I'm so happy to have you. So please, Henk.
Yes, thank you very much. I will load, let's see I have to share now my presentation first. Let's have a look. You can see now my presentation?
Yes.
Yeah, okay.
Yes.
All right. I will be talking a little bit fast because I have to leave the seminar for about half an hour, from about 10 minutes to 3. So I will be a bit quick. So I would like to talk about innovation and more on system innovation and social innovation, and why this choice. If we deal with long-term care issues, if we deal with elderly care issues, most of the care that is being provided is provided by informal carers in society. So it's about 70–80% is internationally regarded as care that is provided by non-professional carers. So if we have to find a solution for what is happening in long-term care and healthcare, we have to look at society, but because probably the solution lies there. I would like to share with you 3 paradigm shifts that are ongoing, at least in the Netherlands, but probably across our borders. It's on views on health, on quality and outcomes, on healthcare, social care, long-term care in their societal context. I'll say a few words on our national quality framework for nursing homes in particular, and I'll give you a number of examples of social innovations in elderly care, which are sort of in line with the statement that the solution should be more in changing paradigms and in engaging the community than in just building more nursing homes or hospitals. First of all, our view on health is changing. The traditional view on what health is all about, we often use the definitions of WHO dating from 1948, which defines health as a state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. And if you take this definition literally, in fact, hardly anyone is healthy, because all of us are suffering from some kind of disorder, discomfort, or whatever. And if we would like to remove all these problems, we get into a very medicalized society, and that's not really what we would like to know. We have what we like to have. We have many long-term conditions, and you have to live with it. And and in the Netherlands at this moment, a new view on health is very popular. It has been formulated by Machteld Huber, a physician, who state, well, health is more the ability to adapt and to self-manage in the face of social, physical, and emotional challenges, which means that we have to focus on resilience of people and to adapt and to help them adapt to this new situation of some infirmity or of frailty. This does not mean that you don't have to treat people or that you cannot cure diseases, but you cannot solve all the problems by healthcare, and you have to facilitate people in living their lives, sometimes in the face of what are the challenges in their lives. And about half of the Dutch municipalities have adopted this concept in their local policies, health policies, in order to improve their societal values, their societal development, and to innovate society in a way that is much more in line with this concept of health. The second, and what you see if you look at this healthcare paradigm, it is not adopted by everyone in the same idea. Machteld Huber said, well, health is about your bodily functions. You can read it on the below line. It's about health functions and perception. It's about spiritual needs. It's about quality of life, social, societal participation, and daily functioning. This is what citizens regard as living a healthy life when the scores on these 6 dimensions are well. However, if you look at what, for instance, that's the pink line, the policymakers, how they think about what health is, they don't consider, for instance, the spiritual dimension as an aspect of health. They're only and also societal participation is something they don't consider as health. So what we see is that the definition of health and how people see health differs across various stakeholders in society. So it's a big challenge to align all these views and to make a sort of a policy which is meeting the requirements and the needs of all citizens, professionals, but also system parties. So thinking differently about health has also its implications for the healthcare system and for the social care system. The second paradigm shift is what we see is on the view on what is quality and what are the outcomes of good quality care. The traditional view on quality is that the doctor knows best. It's a very protectionistic way of looking at quality. It's paternalistic, and a lot of this knowledge was very implicit. And we saw also great practice variation in the treatments of various professionals in healthcare, which was undesirable. Then we saw a development, which is currently pretty dominant, that we were very explicit in what kind of knowledge do you need. We have developed quality standards, we have guidelines, etc. And we had pretty uniform outcomes. We would like to have uniform outcomes. And it's a sort of reductionistic view on what quality is. It is seen as one problem has one cause and one solution. And that's not how reality looks like. And looking at the current and the new type of quality thinking that we have at this moment is that we see, well, we are in a situation that there are explicit and implicit sources of knowledge, what is described as evidence-based in the literature, but also what is in people's lives, how they live, how they operate, what their norms and values are. And we see that when we are dealing with quality, we see that there can be pluriform outcomes. So for various people, there can be various outcomes depending on their context in which they live and the values that they adhere to, what is important to them. If you have a successful operation for a broken leg, for instance, when you're young, that can be you should be repaired so that you can run your marathon again, for instance. And when you're very old, it is nice if you can walk, and maybe if you broke your hip, for instance, it is the question whether you should repair it. So it's very context specific and very according to what the person in question needs and wants, how you look at quality and whether you've done a good job in repairing, for instance, the hip fracture. And the current thinking in our country on quality and how you should use quality is more that it should be a learning cycle where you improve your way of working and where you improve the quality of life of the person you're dealing with. And the third shift, it's a very complicated picture, and I would recommend to read it later more in detail, is in fact the context is the society shift that we see. We come, and you look in the left-hand side, from a paternalistic system where central government says what to do and central government determines what the budgets are and what the protocols are that should be used and considers the citizens and the patients as passive recipients of care and of public solutions. And that was a picture of a few decades ago, but still we have a lot of this thinking. And when we are now in this COVID period, in this Corona period, we see that there is we see paternalistic acting states coming back again. We are seeing much central governance on how to deal with the the coronavirus. After that period, we got into a system which has been called the ego system, where people have the choice, where people behave as customers in the healthcare field and in the social care field. And we saw that there was sort of controlled competition where we organized a competition between care providers to provide the best care and the best outcomes for the best price. It's a little bit where Henrik told about in this privatization movement. And we saw it in many, many countries in the times of the new public management. And at this moment, we see tendencies of moving towards an ecosystem. We see that the government at national level and at local level is much more connecting. It more values reciprocity between citizens, policymakers, healthcare insurers in our country, healthcare providers. Together, they should do the job. And because our society is so complex, and because the care demands are so complex and long-term, there's not one good solution for a problem. It should be developed at local level, and so we see ecosystems developing. We have hundreds of pilots and experiments in our country. Sometimes people say you suffer from pilotitis in the Netherlands, but that's in many countries. And all these pilots are there in order to develop local solutions for local problems and to develop a system with the local stakeholders, how to improve the quality of life of people. I don't say quality of care, I say quality of life. That was not an error. So it is these three paradigm shifts that are ongoing at this moment, and that determine how we look at the long-term care needs and at elderly care. As you've heard from our from our ambassador, it is a big challenge how to find enough people to provide care in the future. And we in the Netherlands are a relatively young country, but we are aging quite rapidly. So it's a big challenge how to find solutions in our society. And it is very important is how do we look at what is health, what is a good life, what's a healthy life, what do we consider as good quality, and how does it fit in a society which is changing. And this presentation is as if there were no corona crisis or whatever. So, and it will be very a big issue how we will come out of this crisis and into what direction of quality of health and of society we are moving to. And that could be an interesting debate for after the break. Anyhow, with this in mind, we had an issue 4 years ago in quality of nursing homes in our country. It were some scandals and there was a lot of criticism. And although we spend a lot of money on long-term care, there are still quality issues. And we developed a new type of quality framework of how to assess the quality of nursing homes, but for all, how can they improve and on what factors should they steer? And in fact, we said there are 8 fields on which measures have to be taken in nursing homes in order to improve the well-being of the quality of life of their clients, their patients, or their residents. First is to deliver person-centered care and support. Second is to provide well-being. Thirdly is to ensure safety. And fourth is to learn and improve the practice of care. These are the blue fields, and they are of a distinct color because that is what you do in the primary care process when you work with nurses and nurse assistants and doctors, etc. You have to focus on these fields. And we say that, well, if you look at person-centered care, for instance, that can be by definition very variable, very diverse for each person. And if you look at safety, we have a few quality indicators which are very objective and which can be measured across nursing homes. But most of the indicators that we use are very local and just for this particular nursing home. And we encourage organizations to use similar instruments in order that they can learn from each other, but they're free to choose whatever indicators they use. In the brown yellowish part of this figure, you see that the use of information is important. So if we say there are no information, very detailed information standards, you still need to use information to know what your clients, how they value your services, how many falls you have, how many pressure ulcers, etc. So the use of information is still important. How to run an efficient organization. Secondly, it's how do you use your resources? It's the lifts, it's the elevators, it's the nose masks, etc. Thirdly, it's how do you come to a good staffing ratio for the population that we have. We had a discussion whether you should have a national standard for staffing, and we chose not to choose this norm, a national norm, but we said, well, there should be sufficient staff according to the facility and according to the characteristics of the clients that you have. And at critical moments, there should be at least 2 members of staff available. And that sounds as a very vague norm. And in the beginning, there was criticism because the people working in the field wanted to have very concrete norms. But we said, well, I was involved in developing this thing, so therefore I can say we. But we said, well, we don't use set norms because every situation is different. Think of this ecological approach. And now, after some time that people got used to it, they really appreciate because they say, well, if you use your good senses, you know when you need 2 or more staff and when 1 staff is sufficient. And fourthly, we were focusing on leadership, governance, management. That's also something that needs to be well ensured and should be well arranged. Well, this is how we look at quality of nursing homes. And this has been a sort of a system innovation because it's encouraging not accountability, or there is still a need for accountability, but not followed by punishment if you don't meet your requirements. But it's a learning model, and it ensures that people are learning and that organizations are learning and improving. And this can be applied to nursing homes, but as I said, it's not only nursing homes where we should find the solution. So I move on now to a number of social innovations that we see in elderly care. First, this is the Hoogewijk nursing home, which has been built and designed as a sort of a small village. And people can live there, and they can be pretty much, they can suffer from dementia quite a lot, but they still are in a sort of a village-like environment, which is pretty familiar. When you see it, there's on the top right-hand side, you see the shopping, the supermarket in this village. You see a central terrace, a meeting hall. You see a bar, etc. So the idea was, we'll make it as normal as possible, because if you suffer from dementia, it is important that you live in an environment where you can find clues for your memory, where you can recognize where you are and what you should do. It's city-like. They have also various types of groups according to their lifestyle. So people who are more city-like people are shared in group, are going together. The Goois, which is a sort of elite type of people in one of the richest part of the country, they also form groups. We have people who have a cultural background, who are an artist, for instance. They live together. People who have a sort of traditional environment in which they would like to live. So we see communities within this sort of nursing home village, according to the lifestyle of people, not according to their degree of dementia or their disease, but according to their lifestyle. I move on to Humanitas, which is a nursing home that said, well, we have a number of apartments, but why should we only have older people in our apartments? So they also invited younger people and students to live in this community, in this, in fact, residential or nursing home, together with older residents. And it's one of the coolest homes in the world, I think the New York Times wrote. And the interesting thing is, people like to live in mixed groups, and these young people live there. They're students, and they pay much less rent than what they would pay on the private market, and they are expected to provide about 10 hours volunteers work every month. And well, as you see, it's pretty cozy, and the old people like it, and for the young people, it's also very nice. It's only 10 hours a month, so they are happy to provide it for a lower rent, and they appreciate the social interaction, and that holds for both groups. A next innovation or movement which is going on, and almost half of the Dutch municipalities are following this, are implementing this, is becoming a dementia-friendly municipality. And that's a municipality where people are being taught in interaction with people with dementia, where there are services which are dementia-friendly, which are easy accessible. There is support for informal carers, for instance, in these municipalities. And so the policymakers and the civil servants are trained to interact with people with dementia. So they can get a label of being a dementia-friendly municipality. And the idea is, you have to start to deal with dementia while people are still in the society. Dementia is on average about 7 years. People suffer around 7 years on average from dementia, and 1 or 2 years they stay in the nursing homes, which means that 5, 6, and sometimes even more years they live in their own original homes or dwellings. And it is important that the society can deal with it and can be receptive to them. We also see many citizens' initiatives the past 10 years in our country. So citizens have gathered together, and they said, well, let us together make an initiative to be receptive, to be friendly to people with long-term disabilities. That can be people with dementia, but it can also be mental handicaps or physical disabilities or learning disabilities. So we see across the country 600-700 citizens' initiatives. They, in the beginning, mainly in rural areas, but now also in cities. This is in Amsterdam, where they have about 20 city villages, as they call it, because their approach is, well, a city is, you can look at a city as a collection of villages of 3,000-4,000 people, a size that you can know each other. So in Amsterdam, there's about 20 city villages in which they care for each other and which they take responsibilities for each other. In the crisis of the agricultural sector, we saw a number of farmers who started green farms, farms where people were older people with dementia, for instance, but also people with mental problems, long-term mental problems, people with mental disabilities, learning disabilities, could go to the farm, do work at the farm, take care of the animals for the garden, etc., and live a life which is sort of normal and not having artificial activities in their institute, but go into the nature and go into the field. And it was very successful. In about 10 years' time, we got more than 1,000 of them. At this moment, there's a drawback because of different funding situation, but also because of this corona situation where a number of these activities are not possible anymore. We also have Alzheimer cafes and network across the country where people meet, have social interactions, something which is music or just fun, but also information about Alzheimer's disease, how to deal with it and how to work with it, and how to live with it in particular. And it's a very light way of a light intervention and a light service, but it is very meaningful for at least a number of people. So what will the future bring? I think we should focus in the future on person-centeredness, well-being, pleasure in life, safety, these types of values, and that it is important that people are interacting with each other and come to joint decisions about what is good in their lives and what is helpful. We should focus on quality and outcomes in terms of what is the client perspective. Can we see that as the leading perspective, looking at autonomy of people, looking at connectedness to other people, and purpose in life as guiding principles. And if we look at quality, it should be about learning and improving. Looking at the societal context, we should the challenge of an aging society is that large and that complex that you have to solve it at local level, at small scale level, is my conviction. And finally, I think the well-being of staff is a crucial factor in quality. If we don't take care of the quality of staff at this moment, we have already a lack of staff. It will be much larger in the future. So we have to be very take care of the staff very well. And finally, the quality of the dialogue between the person who needs care is key. So thank you very much for your attention. And I'm looking forward to the discussion, but I have to postpone it until the plenary session.
Thank you so much, Henk. A very interesting presentation. And Magnus has promised to remember all the questions from Menti. Well done. And then we will come back to you, Henk.
Yes, and now I have to leave for a moment.
But I think it's very important that you give us a framework on quality, because what do we need innovation for? It's to increase quality and lower costs. Henrik was talking about the outcome, and you were talking also about quality, as well as giving us examples of social innovation. The innovation is not only the latest pharmaceutical or robot shower, but it's also a question of social innovation. So very interesting. Welcome back later on, Henk.
Yes, see you then.
See you in a while.
Bye-bye.
Bye-bye. But the rest of us will continue, and please come with comments and questions on Menti. If you haven't logged on, Magnus, you have the number there to Menti, right?
Of course, 2294355. I think it's on the bottom of your screens as well. But please send a lot of good questions. It's fun for me to read and also to ask the questions.
So great, Magnus. So let us move on to Karin Thalén. Welcome, Karin. You are Managing Director for Stockholm's sjukhem, and you have the title Collaboration Across Silos. Very interesting, with a set of innovation aspects into that. And you will also give us some views from Stockholm sjukhem, a hospital in Stockholm. So please welcome Karin.
Thank you, Katarina. My name is Karin Thalén, and I'm a hospital manager here in Stockholm's sjukhem. And we are also a member at Forum for Health Policy, I must say. I'm so glad to be here today. I will talk about collaboration across silos, and now I try to share my pictures with you. Just a moment. Can you see?
Looks good.
It looks good, thank you. But I can't see it. Can you please help me, Emma or Johan? Okay. I can't use the pointer to switch pictures. You can see my picture. Please, can Emma or Johan help me?
Hi, Karin.
Hi.
I think you might be on the wrong screen.
The wrong screen?
Yes, because we can see your picture, your presentation. And now,
is it okay now?
Yes, we can still see it.
Yeah, thank you, thank you. Now I think it works.
Okay, thank you.
Thank you. In 1860, Professor of Medicine Magnus Huss initiated a fundraiser for the establishment of a care institution for the poor and incurable ill. 7 years later, in 1867, the Stockholms sjukhem Foundation could open. And we are still very close to our original address here at Kungsholmen in the city of Stockholm. Now as then, our focus is on caring for the long-term and incurable ill. Today we operate on 2 different sites, Kungsholmen and Bromma, all in Stockholm. And from February next year, we also are present at Södermalm in Stockholm. Stockholms sjukhem is a non-profit private healthcare provider owned and operated by the foundation with a strong sense to manage our history and our basic values to be accurate for the future challenges. We provide high quality care in several areas, as you can see, such as geriatric care, palliative care, rehabilitation, and elderly care. We facilitate both inpatient and outpatient care for about 350 patients every day, and we offered advanced home care for more than 200 patients each day. In our nursing home, we have 102 apartments. We also have a very strong research development and educational department in-house, and we have about 1,300 employees. Collaboration across silos is a challenge, both between the municipality and the county, as well as between different specialities. Many organizational setups today are based on a silo thinking and traditional care logic. In the future, we need a new logic to meet the challenges ahead, driven by the demographic development. Primary care, hospital care, domestic care service, and elderly care in nursing homes are all organized in public and privately owned organization or companies. They all want to collaborate, but it's not always an easy task due to the reimbursement regulation and tender procedure. I know it's possible because I have been experienced a successful model in Norrtälje, as Peter told us. The 10-100 model enhances cooperation and removes the boundaries that are not needed between public and private and between the municipality and county. By collaboration, it's possible to reach a higher quality for the inhabitants. I worked there between 2006 to 2012, before Peter arrived to Norrtälje. Some facts about Region Stockholm. Region Stockholm has overall responsibility for caring for the county's inhabitants and must meet the targets of the Swedish Health and Medical Services Act, which means good health and care on equal terms for the entire population. The region is one of Europe's largest healthcare providers, and it cares for approximately 30 to 35% of all care in Sweden. Most of the care is provided under the Region Stockholm's own management in the public. Around a third is dealt by private care providers such as family doctors, physiotherapists, maternity clinics, and hospital. We have a system, we heard Henrik told us, called Vårdval Stockholm, free choice of care. Vårdval Stockholm that gives the county's inhabitants the opportunity to choose care providers based on their own requirements, such as geographic location and opening hours. Reimbursement to caregivers is based on inhabitants' choices. By the end of 2017, there were approximately 2.3 million registered in the county. Year 2027 is calculated to be an increase to approximately 2.7 million. And by year 2060, the calculation ends up at 3.3 million residents. That means an increase of a total of 1 million residents by the year 2060. So by the end of the day, we really need to collaborate over the silos and really make sure that we provide the best possible care and welfare for all inhabitants. The city of Stockholm, in Sweden and more specifically in the city of Stockholm, the number of elderly in need of care are rising over the years. According to the city's official population forecast, the number of elderly people over the age of 65 in the city of Stockholm is expected to increase in the coming years. The largest population increase is expected to take place between 2020 to 2030. The forecast population increase is greater in the inner city of Stockholm city compared to the city as a whole, and this is where Stockholm's sjukhem operates. We are expanding with a new nursing home on Södermalm, the south part of the city, from February next year, and we see a future in expanding even more over the years to come. There are many different silos to talk about and collaborate in between in healthcare, one being the medical silos in healthcare. We need to consider two revolutions that both are having a real impact, the medical and the digital. These are disruptive events, as the possibilities for personalization and freedom in time and space are paradigm shifting. The third revolution, which many talk about but few can concretize, is the organizational level. Therefore, many of the challenges remain. The need of and the ongoing simultaneous changes make the proportion of complicated, chronic and complex patients increasing. At the same time, larger parts of care are individualized and move to patients' everyday social context. This new landscape is illustrated by using a quadruple that shows different patients groups that between themselves have different needs and our consumption patterns. The 4 patients group you see are chronic care, a never-ending care, often within one specific specialty and in need of continuous care. And then you can see the complex multi-sick care, often an elderly, fragile patient. And you can see easy care organized by functionality and organ. Complicated care, as you can see to the bottom of the right-hand side, patient flow throughout the system in episodes, but there is an ending on every occasion. The challenges that await healthcare and elderly care are great and exciting. Being a nurse myself, I see how much the nurses in our organization administer, plan, document, and try to make all logistics works for the patient during the care period, but also before the patient is discharged. Today, you can treat diseases and operate and rehabilitate well into the years, but we have less and less time for human contact. And we heard Bengt talk about it. Technology gives us great opportunities, but we must not make healthcare inhuman. It's about increasing demands from a growing population, about patients who are becoming increasingly knowledgeable, connected, and can do more and more themselves. About new ways of working, treatments, and drugs to be developed and disseminated. About digitalization, urbanization, globalization, and smart technology that pushes boundaries and views on who does what and how it's done. For this reason, managers at all levels must be involved in development and innovation work and support. With a person-centered approach, we see patients and residents as co-creators when we design and evaluate new knowledge, service, and services. Employees' professional knowledge is an important aspect in implementing change in a successful way. Professional knowledge is a combination with improvement knowledge is crucial for the result. The work is carried out with mutual respect and partnership that invites profession, patient, and residents' strengths and expertise. Now a few words about the COVID-19 pandemic and from the period February to November at Stockholms sjukhem. Let me just mention a few words in regards of the pandemic and Stockholms sjukhem. We have given care to more than 500 patients with an overweight on our geriatric clinic, as you can see. We have had more than 76 patients admitted at the same time in April. Protective equipment was unfortunately not in place from the beginning, so we started in-house production. There was a high stress level amongst the staff, and HR, human relation, was very supportive. Staff had and still have the possibility to have talks and dialogues with professionals outside Stockholms sjukhem. We have been involved and contributed to the Forum's report, which was published in August. It contains 7 policy councils, as you can see at the picture, some of which I think are particularly important. We need better coordination between healthcare and healthcare actors. Today, it's difficult to navigate through our healthcare system as a patient and relative. An example is sampling costs that are made unnecessarily because IT systems do not talk to each other. Another is the old-fashioned handling of summon systems and referrals used by healthcare. I can do my banking errands and book my holiday travel with my bank ID. I can follow a package from sender to my door, but I can't follow a referral in healthcare. Despite the digital development, we need hands and feet in the health and care. Reduce the unreasonable requirements that exist in terms of administration and accounting. Let us create a more trust-based healthcare and give more time for our patients and relatives. Yet there are also opportunities. Some innovations are now quickly being taken up. What previously took months and years to implement can now take a few weeks in this pandemic experience area. Digitalization is taking great strides forward. Decisions that previously took years to investigate and decide on have only been implemented because they must be made here and now. This shows that there is an enormous potential in the healthcare staff, a potential that is not used in its full today. After the acute phase of the pandemic, much can be learned from that work, what worked and where it broke. However, challenges were large for Swedish healthcare even before the corona crisis. When the emergency situation is over, the long-term discussion must be less about demand for more resources and more about how resources can be put to better use. At Stockholms sjukhem, we have 3 research, development and education platforms. We always want to develop and execute innovation between our business areas across all specialties. And here are some results. Business integrated development is created when RD&E's role becomes consultative and on demand from the business organization. RD&E is requested to support the profession in their work to develop the business based on needs, requirements, and expectations. Professional knowledge in combination with improvement knowledge is crucial for the result of the improvement work. As we say, we have 2 jobs: to do what we are trained for and one to develop. Stockholms sjukhem wants to provide a seamless chain of healthcare for our patients, extending overall traditional county and municipal boundaries, built on collaboration between our specialties, geriatric care, rehabilitation, palliative care, and elderly care. Our intention is to meet the need more collectively that healthcare and overall elderly care is in an organization that makes it easier for our patients and residents. The goal is to minimize and, if possible, avoid for the elderly needing to go to an emergency department unless medically justified. The patient should not have to navigate and understand the structure themselves. It's our job to make sure they are taken care of at the right level and with the correct medical and social conditions. We can and should always meet the needs in medicine, nursing, rehabilitation, and social, and by doing just that, we provide a better quality of life for those who live in our nursing home and our patients at our hospital. During the pandemic, geriatrics and rehab units was reorganized and ran COVID care together. Advanced home care was ready to take COVID patients. Palliative care assisted the region in staffing the Feld Hospital in Älvsjö, but also in supporting geriatrics with the infection consultant and assisted the region in developing a basis for the care of COVID patients in palliative care. We accelerated the digitalization with monitoring of patients in advanced home care and with reading tablets for the nurses working with inpatients care. There is a definite challenges coming to elderly care, and during spring 2020 it became clear for many that the structure set up in Sweden for our elderly in residence is not the best. The life expectancy is increasing, and thanks to great health care, we stay healthier and stronger even when we get older. That said, we also have a growing issue with the isolation of our elderly, as we tend to live at home even when we get lonely and weaker. The social impairment is accurate and hard. In Sweden, since the beginning of the 90s, we offer and push for home care in a wider perspective than earlier. To get a residential place at a nursing home is decided by the municipal and not always based on medical and social reasons. The goal for the municipal is to give domestic and home care for as long as possible. Another challenge that is already here is the lack of medical competence in Sweden. I won't go into why, but can just state the facts. That's the way it is. Since 15 years ago. Several activities are getting in place to educate and train more nurses and doctors with a specialty geriatrics. At Stockholms sjukhem, we appreciate and invite educational centers to send their students and doctors to us. Stockholms sjukhem make a unique investment that provides an opportunity to improve the state of knowledge and develop care and nursing for the most sick and fragile elderly. We have about 20 ongoing research projects, and we produce about 50 original publications, and in total 2,000 student weeks nurses per year. Stockholms sjukhem is approved as a unit for university healthcare from next year. To accomplish the best care for the individual, we do need good collaboration with the emergency hospitals such as Capio Sankt Görans Hospital and the Karolinska University Hospital, as well as the primary care and municipal healthcare. Naturally, we need to cross the silos within our own organization as well and put what patient and residents need first in all we do, think and say. This might sound obvious, but it's sometimes easier said than done. However, this is something management and our HR work with every single day. Through our values and the strong base in our foundation, we see how the staff, regardless of positions, do their very best every day. Trust that we can provide good care and attention with less administration and requirements for control and accounting. If we are to be attractive to tomorrow's employees, we need to modernize our healthcare system and take advantage of the opportunities provided and not give into inertia, rigidity and old power structures. Give the patient more power and let the patient navigate with a new technology. Then it will be person-centered care for real. The hierarchical structure we have in healthcare requires courageous leadership that dares to challenge and change, but that we really can achieve collaboration across silos. Thank you for listening.
Thank you, Karin. That was great. Very interesting, and there's so many things that you were touching upon. And I think one of the most challenging tasks is to actually get that seamless care where there are so many different providers actually in one chain of care for especially elderly people, and that's where we need innovation. Now I know that we have some questions on Menti, right, Magnus?
Absolutely. And I can go with a couple of questions before the break then, because now you need a break after some good but long presentations. The first one, Karin, now you need to be on your toes. Why should the IT system talk to each other when the professionals in healthcare system and its organization does not talk to each other?
It's very important that both the professionals and the IT system can talk to each other, because then we can deliver very good healthcare and elderly care if they can talk to each other. It's a very important issue.
I agree. It was just such a nice written question, so I just needed to raise it. How do we get managers and employees in healthcare to see digitalizations as tools for developing and improving the business, and see the tools as opportunities and not obstacles?
We must. I think the biggest issue is to be brave and show courage when we recruit managers to healthcare. We need both leadership and management who can take care of the patient, relatives, and the employees. And I think we need to have more pressure on our managers. We have to what do you say? Let me think a little bit. Do you have another question?
Of course I have. The last question before the break. It's always a nice one. Most of the Swedish regions and municipalities are very conservative and would not like to try new innovations and keep continuing the long-running routines. Are Region Stockholm being a role model and a leading regions out of the others? And if yes, why?
I think it's because 30 to 35% is private providers, both non-profit and for-profit actors, caregivers. I think that is one answer.
Yes. That's good. We end before the break then, Katarina, with Karin saying that private is better than public.
So, okay, thank you so much, Magnus, and thank you, Karin. And we're now going to have a short break before we introduce Andrew Pace. I'm so excited, looking forward to Andrew's presentations. Karin, I think you have to mute your microphone.
Sorry.
So in 10 minutes, or to be exact, 8 minutes, we will be back. So don't miss it and keep on sending questions. Please.
And use the break to run out in the garden for a while or something, so that you are energized when you come back.
Yes.
Let's see you in 7 minutes.
Jump up and down. Welcome back, everybody, after this short break. So happy to see you, everybody. And now let's move on to Dr. Andrew Pace, head of iHome Lab. Very interesting think tank and research center for building intelligence. I think we all need more intelligence, Andrew. And you are going to talk about user centricity for the elderly. Really looking forward to that. You're so welcome. Please.
Thank you, Katarina. Thank you very much for this invitation and this opportunity to present. Bit of a contrast to the previous presentations, because I'm coming from a very technology-centered point of view. People have been talking about patient-centered care, that we need to be centered on our patients. People have been talking about innovation and can it help us? And it makes me really happy to be able to present now, because those are exactly the outpoints. So I go into presentation mode. We're going to have a fairly, a very multifunctional, multimedia presentation. I start with a set of slides, as my predecessors did. So I hope you can see my presentation now. What you see here is the iHome Lab Visitor Center. So the iHome Lab, we are split into two parts. We have a visitor center where we show our research, and then the research center where we do our research. And this here, if you could come and visit us in Lucerne, Switzerland, is what you would be able to see. Just a brief introduction. So we do user and application-oriented research projects. We have about 20 people. Well, it's actually 25 people, but a lot of people working part-time, so we have 20 full-time equivalents. We have, over the last 10, 11 years, worked with over 170 different partners. So there's SMEs, people from industry, business, end-user organizations, and so forth. And also we are coming out of the area of embedded systems, IoT, these sorts of things. Therefore, we also have a certified BACnet test laboratory. I don't expect you to know what BACnet is. It's one of these thousands of protocols when you're working with smart homes and the like. And probably our USP is that we have this iHome Lab Visitor Center where we do guided tours and demonstrations, where we really show people what is our research and how can technology help to change. We use storytelling and we show very little technology, actually, but you'll see a bit of a view into that in a second. So we have three areas of research. One is smart energy management, sort of smart grids, demand response. One is called safe building intelligence, which is all about digitization, smartness. As Katarina said, we all need more smartness, maybe intelligence, maybe smartness, we'll see. And the other is that, and that's really the topic of our presentation today, is active assisted living. So active assisted living is technology to enable elderly people a longer, active and also independent lifestyle. The key word here, which is not unfortunately here, but which we use all the time, is a self-determined lifestyle, because we want to be competent, we want to be autonomous. And it's the same for people of all ages. And here we are investigating what is the various uses of technology to improve this. As mentioned, we have our visitor center. In a normal year, we would have about 3,500 visitors per year. Unfortunately, the COVID pandemic has really killed things. The second quarter, for instance, we had last year, we had 1,000 visitors just in the second quarter. And this year it was 29. So it's really having quite an impact on the way we work. So the way that we work is actually we apply user centricity in all of our work. We start with the users. We then try and elicit their requirements via workshops and so forth, move on to system design, implementation, and go into a field trial. Usually the first field interaction is really rapid prototyping. We speak to people, we say, what if is this technology something which will work for you? And then we do another iteration of design before going to the second round of field trials. So everything that we have done, all of these many projects we have done, we've been talking to the users, we've been trying to pick up what their actual needs are, and then I have various examples where this has actually led to a change in the project scope, the change of the project goals, because we found out that perhaps the first hypothesis we had as to what would help people in a particular situation, elderly people in particular, is not what they need. Or perhaps, and probably the most common mistake, particularly when you've got too many engineers working on this, is that the solutions they develop are much too complex and you have to simplify. So this is really our thesis. By taking a user-centric approach, we can design technology to help the elderly lead an independent life, to improve the quality of life. And then in order to introduce that, I have created a short film, well, short, relatively short, 15, 16, 17-minute film, in which you will see some of these impressions, and these are impressions you would get of the iHome Lab when you came. So I would hand over to the studio now, and they can transfer to my avatar at the iHome Lab. So welcome to Switzerland. Welcome to the iHome Lab here at the University of Applied Sciences in Luzern. Here we want to tell you a bit about our research into active assisted living, research for elderly people. Now I'd like to go into our visitor centre. I'd like to ask our butler, James, to open for us.
Hi, nice to see you again. Shall I open the gate for you?
Yes, please, James.
Emma, Johan, we're waiting for the film.
Yeah.
Welcome. I'm James, the virtual butler of iHome Lab. I hope you have an
this with technology is always interesting.
Have fun.
It was interesting. We did a dry run last week and it all worked perfectly. So if it's not working, of course I can try streaming the video here live, but it would actually be better if it came from your studio.
Visit, you would actually see a 10-minute film which explains what it is we do. Because this is not currently possible, we show you a short introduction. Now I'd like to hand over to James. He's going to show you a brief
the coffee break.
Introduction to our
It's actually on.
Hi,
you
I'm
don't
back
see it.
again. Now let me take you into the fascinating world of the iHome Lab, where I show you which topics we are working on, and how, together with our partners, we are creating innovative solutions for the future.
Then Magnus, you perhaps have to give
The
me a
world
bit of a
population
countdown so I know when it
continues
is.
to grow. Life expectancy is increasing and living standards are rising. This has consequences. The most obvious one is simply, we need more. More of everything. More energy, more food, more living space, more care for the elderly. Simply more of everything, and all on a planet with limited resources. Things could get pretty uncomfortable in the long run. Under the motto, Living in the Future, today, we perform research into meaningful technological solutions, so that hopefully, things won't get really uncomfortable. And now I'll take you into the deepest depths, right into the heart of the iHome Lab.
Please join me and I'll tell you something about our active assisted living. So in order to explain what it is that we're doing in our research on active assisted living, so that's research to enable elderly people to stay at home as long as possible, we tell you a story. We tell you the story of our only inhabitant of the iHome Lab, Anna. As you can see, Anna is an elderly lady. She's in her late 80s. Her husband, unfortunately, no longer with us. Children have all moved out. But she's able to live at home quite well with the technology that she uses and integrates into her daily life. Here you can see, for instance, our electro rollator. This was a project we did in the AAL call 2010, for which we won a prize for the best project in 2013. This was at a time when the first e-bikes came about, and she could use this, the sensors here in the grip allows you to go up and down and over any sorts of terrain without even noticing that you're in a different, that it's not being on a flat. Anna, of course, also uses the other things. You have here integrated things like navigation, but also the shopping list. So Anna has just come home. She's scrolling through her shop list to see, do I have everything? Have I bought everything that I need?
Du hast eine neue Nachricht von deiner Tochter Claire.
Of course, in the future, all of our devices are purely integrated. She doesn't need to have a mobile phone to get a message. Rather, she gets a notification here. Of course, Claire is her daughter, so she's wondering, what is it that Claire has said? So she says, okay, tell me.
Ich spiele dir die Nachricht jetzt ab.
So I don't expect you to understand Swiss German, but the message is from her granddaughter. Got a bicycle, for her birthday just a few weeks ago. And look, now she can already ride the bike without training wheels. Anna, of course, wants to immediately reply. Perhaps she doesn't know what's going on with over there. In any case, what she does is she makes her way here, forgets all about her shopping, and makes her way across to our magic cube over in the corner. There she is on the way, and then, unfortunately, she's a little bit distracted or something, and then it happens. She falls down. So what's going to happen next?
Hallo Anna, alles in Ordnung? Bitte gib mir eine Antwort.
So Anna is of course not the only inhabitant of the house. We also have James. James is watching out. And what's happened here is that Anna, she's wearing one of these fall detection devices. Fall detection devices, they were part of our research about 10 years ago. These days, they're commercially available. You can buy these and integrate them into your system. So the question is, what happens now? Anna hasn't answered, and James knows that something's happening, so he has a possibility. The possibility he has is he can send me a message. So here, for instance, on my phone, he has sent me a message saying Anna has fallen. And if I'm at work, I have to see what's going on. With this, there's also, for instance, the integration of access, permissions, and so forth. And then I can switch on here the webcam. So there's a webcam just over there where we can see that there is Anna lying on the ground and unfortunately not moving. What can I do? I'm a little bit further away, so the best thing I can do is to escalate the situation. I can now send the alarm on to the emergency call number. This was a film sequence that we took with the local emergency centre, and just as I got the permission to have a look into Anna's room and to see how she's going, also we can imagine that the lady at the emergency call centre can also look in. So she also now has access to the webcam. She can see Anna lying there, nobody around to help. Can have a quick look and see, okay, EKG. You can see that the heart's still beating, so she's still alive, but obviously she needs help. This sounds like science fiction, but in our research we're looking at different sensors, LIDAR, 3D cameras. Also, of course, we have Fitbits, these sorts of things which can measure heart rate. So she can see now Anna is alive and in need of help. And then she can have another look perhaps at the medical records, see what's going on there. And when she sees and decides, okay, now we need to send somebody, she can call up a local map of the area, sees which ambulances are there, which one is actually available, can take all of this information and then drop it down with the GPS coordinates and so forth, which mean that they can take off immediately and come to us up here at the iHome Lab, zooming around Hall. This is the suburb where we are, until they come finally screeching to a halt in front of the iHome Lab.
Der Rettungsdienst ist eingetroffen. Ich öffne die Tür.
Of course, this is another time where you need some technology or something like James. If he wasn't there to open the door for the ambulance, then of course they would have to break in. It would cause damage to the house.
Anton, das ist Christian, 121. Was mir dann Patientin vor Ort, Kreislauf stabil, Nährwert, Status 5.
So status 5 is the happy end. This means that actually as Anna is feeling good and the ambulance is now ready to be used for something else. So Anna is now okay. She is now fine. We can put her back to be ready for her next trip here at the iHome Lab. Her next job here at the iHome Lab. So she will stand here and wait. So this is also an example of all the different sorts of technologies and things which we use for the results which we are getting out of our AAL research. And if we look here at the wall behind me, we see various other examples of research which we have done and other projects which we did. For instance, this first one here, relaxed care, is this cube. The cube started out as something which would then monitor the elderly and send me a message. We quickly found out this is a very bad idea. We need a two-way communication. We need something which is very, very simple. So we have these tokens here. So if I take a token, for instance, this blue one, I put it on the middle here. it detects it, and then I get a notification either on the second cube, which is over in my room, or also on the app which I have on my phone, saying, I know now that my mum wants me to give her a call. This is one example of the research that we do. So another example of the research that we do here is also a lot regarding the interactivity, and also how do we have to design user interfaces so that people with dementia or just elderly people who are not used to electronic devices can also use them. One example here is called Sam and Me. This is this one here. If I give it a double tap like that, it switches on. We get a very simplified interface here. I can only do a few things. I can say, okay, what's the weather going to be like? And you have Sam who comes and tells me what the weather's going to be like. And anytime I want to go back, I just give it a tap, and I have possibilities here. Another example here on the shelf below is called Kith and Kin. This was something which we did for elderly people who are in an isolated situation. It was also an experiment to see how can we take very simple materials, so just a tablet, and then a couple of 3D printed devices, which we can then click it together, and then something quite different comes out of this. And the interesting thing here is simply that this is still touch sensitive exactly on these points here. And so I have an extremely simplified interface. If I want to call someone, if I want to exchange pictures with my friends, or if I want to play a game. This is something for very specifically for people who are living in isolation. Here we have a couple more examples. These are somewhat older projects which have now managed to make it into the market. This one here, for instance, is the project which we did, the iSense. This is actually an inactivity sensor. So in contrast to the other devices we've been looked at which measure something, this is actually a device which recognizes typical activities, and then when they don't happen, it gives you an alarm. So for instance, if an elderly person has not got up in the morning, or if usually they would get up and go into the kitchen and this hasn't happened, then you get an alarm that something different has happened. So another project which just finished last year was Home for Dementia. This is all about how you can make your home help you to evaluate whether or not you have a problem with dementia. We're using here typical sensors. For instance, this is a pressure sensor which will go into your bed. When we put this in, then it starts measuring when somebody has been in the bed. It can start measuring their sleep, how well they are sleeping. The next one is a multi-sensor. This is something we've developed ourselves here at the iHome Lab. This is something which will go into the kitchen. And in the kitchen, it will then measure air temperature, humidity, perhaps some noise and so forth, and can let you know whether people are in the kitchen, whether they're cooking, typical daily activities. This is about the whole activities of daily living and how we can identify them. The final sensor which we then put into the mix is a typical presence sensor, not something we developed, but rather something you can buy. So you have a presence sensor which then says whether somebody's in the living room or not. And so as a result of this, you can start to put together a picture of the daily rhythm of the people who live in this apartment. And this is a key point. It's this daily rhythm, because the daily rhythm is actually fairly deterministic. We are all creatures of habit. So we repeat ourselves, we get up at the same time, we go to bed at the same time, and this starts to break down. This can be a sign of dementia. So this was the second part of the project. If you start measuring these over time, you can then also measure how regular they are, what sort of a rhythm this particular person has, and you can start to see when this breaks apart. So here in this simulation, you can see, for instance, that somebody starts going to bed in the middle of the day, they start going into the kitchen and cooking at different times. This whole daily rhythm falls apart. And part of the research was to measure this in a real situation, and also to develop a sort of an artificial intelligence algorithm which can take this and say, there's a chance now that you have dementia. It would be a good idea to go to the doctor. So another project we're doing is in collaboration with the University Hospital in Bern with the Institute ARTOG. The project is called Cyberhuman Parkinson's, and it's all about detecting the effect of Parkinson's, or more specifically, to gather more data on the way that the patient is reacting to the drugs that they take, the medicine that they take for Parkinson's. So one of the things we are using here is actually these sort of Fitbits, which can measure the acceleration. So what we have here is one of these typical polar watches, and we can then measure actually the acceleration. Now, of course, 9.8 meters a second. And then if somebody comes into a tremor situation because of Parkinson's, then their hand starts to vibrate. And we can measure this. So we can measure this, and we know then when does the person have one of these Parkinson's tremor attacks. We can then correlate this with other information. The picture you see at the other side, which we can show if you were here down at the iHome lab, this is how this integrates with localization. Where am I when this happens, what time of the day it is, and so forth. And this gathers us more and more information, which we can then collate and put into a presentation, sort of a dashboard for the doctor, so they know better how to adjust the medicine which they're giving this Parkinson's patient. So I hope you've enjoyed this short glimpse into the work we are doing down here at the iHome Lab in Switzerland. We have gathered a few ideas of what we can do to make the life of the elderly better in the future. Hopefully, I can also greet you in person here in the very near future.
So, I'm not sure if there's anything else I need to say after that, huh? So I don't know, Magnus, how I'm doing for time. If we go straight to questions now, I have, of course, another 50 slides, which I could show you details on all of the projects and the rest, but I think I'll spare you. You get the idea of what it is we do and how we work.
Perfect.
So thank you very much, Andrew. I'm a technique nerd myself, so I love all these different examples actually. But since I had my mother also at an elderly care home for 5 years before she passed away, fortunately. But the thing she was talking about all the time was to lead an independent life. And the more diseases she got and the increased immobility, I really wanted things for her which weren't available in order to help her to lead an independent life. And I also remember when the Japanese introduced shower robots 10 years ago or 15 years ago. Time passes so quickly. And all the people said, oh, how could they? Actually exchange people for robots in the showers. But then when you talk to people who needed help in the shower, who did they prefer? They prefer the robots. Of course, they want to have humans talking and taking care of them. But so I think it's to lead an independent life is a very good vision.
And I think that you've highlighted a number of points there. We as humans have three basic needs. The one is to feel competent, the other to be autonomous, and the other to have a social interaction. And I think that technology can help us, can augment our capabilities so that we can be autonomous. And exactly what you're talking about with the shower here. Of course, I would rather have a robot to help me in the shower because then I'm not depending on a person. I'm then determining what is happening. I'm feeling that I am in control of the situation. And this is the direction we try and go with our research. We try and develop technologies which help the people, but keep the control in the place of the people and don't take it away from them. I think this is often a misunderstanding by people who are not involved in these projects, that they think that we as technologists, we want to take control. That's never been actually the goal of automation. The goal of automation is to increase efficiency and to enable people to do more than they could before, not to take things away.
Magnus.
Yes.
Any questions?
There's a couple of questions. The first two questions came from, can you please stop talking during the film? And that was a valid question, to be honest. You don't have to answer that, but we noticed. Then you have two really good questions that I like to ask. First of all, what challenges do you see when you look at the traditional user-centered techniques? Appropriate application design and evaluation fail to properly support infrastructure design and evaluation.
Okay, so I assume this is somebody coming from the design thinking community. So you're looking very, very closely at people, at just the single person. This is one of the learnings that we have made. You can't just look at the person, you have to look at their context, and you have to look at their situation. With elderly people, as we've heard in a number of presentations before, Henk mentioned it, Karen mentioned it, and so forth. I think even Henrik touched on it, that you have these informal caregivers. You have so many informal caregivers, and this has such a huge influence on the life of the elderly that we even have some projects which are purely centered on supporting the informal caregivers. So supporting just their families and these sorts of things, supporting perhaps the ecosystem which is around them. And so this is where I see not necessarily that design thinking on the user-centric approaches are failing, but rather that you have to expand the scope. When you're thinking about who is my user, it's not just a single elderly person. It's perhaps their son, their grandchildren, it's the people they talk to. And we talk about here the grandchild trick. If you want to introduce technology to elderly people, it's often more effective to give that to their grandchildren and then say, hey, go talk to your grandmother about this, than to give it to their children or to a carer, because they interact completely differently with their grandchildren. The technology will be accepted then. Yeah.
Good answer. Thanks, very interesting. How do you benchmark yourself internationally? Scandinavia has a lot to offer in terms of monitoring. More exchange could be beneficial.
I mean, I would be absolutely welcome to, happy to exchange with more people in the Netherlands. We have, let me quietly think briefly. Of course, I know, I think in Switzerland we're the best there is, if I wouldn't be able to say anything else. Internationally, we have very good track record. We've done dozens of projects in the joint program on AAL. And these are always with European consortiums. And so I think we can measure with the best of people around Europe regarding our knowledge, in particular on this intersection of technology and solutions to help the elderly. So smart home solutions, the extension of smart home solutions to smart environments. I think we are really, really amongst the best. And like I said, we have a huge focus on how we disseminate our technology, how we show people. We're very involved also with local societies for the elderly. So, you know, care organizations, but also community organizations. And this gives us a bit of an edge. But I'm very open to collaboration. All of our projects, we don't have any university-funded projects. These are all funded by the EU programs or Swiss funding, which means we always need partners. We always need consortia. So I'm always very much looking forward to collaboration with other people. In fact, one of our greatest collaborators is a Dutch company, Vertask. So it's why not put Sweden into that as well?
That's good. I think both Sweden and the Netherlands are interested in that. So, okay, here's a question with two dimensions. First of all, there was a lot of cool tools. What is your favorite? And that was the first part of the question. And the other is, of all these tools, how many of them are working in the society for the elderly, and to what extent? I mean, I can understand that some of them are in test beds, but to what extent are they working in society?
So the iHome Lab, as I demonstrated it just now, this is really a dissemination tool. And everything, like for instance, the ANS showcase, this is something which everybody can understand and relate to. But if you look at it, there's a mix. You have these things which are already in the market, like the fall sensor and these sorts of things. And you have things which are perhaps interesting. I mean, Karen talked about this integration of information across everything, but we're not there yet. So this is where things are just over the horizon, and then there are other things which are science fiction. So something like James that can really interact with us in a natural fashion, the way we envision that doesn't exist. So what do I think is cool? Cool always takes on various things. Actually, this walking frame, the motorized walking frame, I think this is pretty cool. That was way before my time at the iHome Lab. I've only been in the team for 2.5 years now. But this is one thing we had the experience that some of our field test subjects, they just didn't want to give it back. Because in particular, one old guy that he'd been going for a walk in the forest for years and years and years. And because he was becoming a little bit fragile, he could no longer do this safely. But when he had that, he could do everything once again. And these are the things which I think are cool. So from a point of view of activity on helping people to get outside, I think the rollator is really one of the good ones. From a purely technical one, there's another technology which we didn't show. That's the one we're doing with the company out from the Netherlands. This is an avatar, speech recognition, speech-based interaction. This is really quite cool. And then what you can do with the data in the background. Yeah, that's what I personally think from a purely technical point of view is cool. But from points of view of enabling people, I think we need to go more in the direction of the rollator. Yeah. Did I answer both questions? There were two.
No, you answered the first one. The second part is, okay, when it comes to utilization in the society, I mean, where are you when it comes to that?
Nowhere near where we want to be.
The relator is not everywhere, but it sounds like
it's nowhere where we want to be. I mean, like I mentioned with the fall sensor or the inactivity sensor, these are things which have made it into the market. Also, this avatar solution, which I'm talking about, this is also in the market, but the penetration is very, very low. And doing a little bit of advertising for the blog entry that I've written for Katarina, I have the feeling actually that we need to, there's been a lot of moving now towards saying, okay, we've done so many cool projects, but there's not enough in the market. What can we do to improve it? And everybody's moving to startups and these sorts of things. But I think there needs to be a bit more of a mix. I'm not sure that we've found the right technologies. And part of this is also the fragmentation of the market. So we have very different, in this project we have very different cultures in different countries, very different needs. So for instance, this Home for Them project that I mentioned in the film, one with the monitoring of elderly people, determining their activities of daily living. The first problem we had to contend with was actually the quality of data. This is what Henrik mentioned at the very beginning. It's very difficult to get these sorts of systems working. And then the second thing was very surprising. We had 3 test sites, one in Switzerland, one in Germany, and one in Italy. And you could actually see from the data which country the people lived in, just purely based on when do they get up, when do they go to bed, do they spend more time in the kitchen or the living room, and these sorts of things. And this means then that all of these solutions we develop, they're either extremely focused, it provides one functionality, like I fall over and it detects something, and many people look at that and say, this is not a complete solution, I don't want it. Or it's a complete solution, but it only suits this particular country, this particular healthcare system, this particular way of paying for things. This is the other question. Who pays for these solutions? Do I pay? Do my children pay? Me as the elderly person, do I pay? My children pay? Does the health system pay? There are all of these sorts of questions. And who actually benefits from this? If I stay at home longer, yes, I want to be autonomous and I benefit from this. There's also a benefit for society because I'm not taking hospital beds and so on and so forth. So there's a lot of open questions there regarding just how you actually bring these things into the market. Yeah.
Catherine, I think that was a perfect segue to the panel debate, that everything is not working or everything is not perfect in Switzerland rather than in the other countries. What do you say?
Yeah, I think so too. I don't know what you mean, everything is not perfect. So yes, definitely. So let's continue to that panel debate, and as I see it, you have a chance here to continue asking questions and comment also on the panel debate. It's always a challenge when you're online, since it's good for me as a moderator because I can decide who to talk, so nobody can interrupt each other. But let me turn to Barbro Westerholm, and I'm so happy that you're on board, Barbro. And you are really qualified. You are a medical doctor and you are a researcher. You are also a civil servant, a former civil servant. You have been and you are a member of parliament for many years. And you're also an expert when it comes to healthcare and elderly care. Now, we have heard a lot of different aspects on innovation, but I would say that the aim is always to improve elderly care, and innovation can be a part of that. And especially looking at the COVID situation now, for example, what are your reflections, Barbro, in order to improve and help elderly care to get better? Welcome.
Thank you. Well, my reflections I think COVID-19, despite all the deaths and all the bad things happening, it has put focus on older people. And it's so obvious that society before saw older people as a collective, not as individuals. And I can see from the papers you have given today that there is a change, a positive change, that older people are individuals and they become more and more different as the longer they live. And therefore we have to have a society which meets the different needs, demands from this generation. And this generation should not be age discriminated, as it has been for thousands of years, actually. But now we have to give their quality of life to everyone. And the first paper dealt with privatization, and I think it has come to stay. And in the investigation I'm leading on home care for older people, we see no difference. Maybe a slight better quality in private situations, but the indicators are not that good. And you have also put that forward, that we need better indicators in order to measure quality of life for older people in care homes and in their own homes, but also quality of life for staff, because I think we have to shape a good environment for both of them. And then I think this with meeting needs. I think in the Netherlands, you had a catastrophe a couple of years ago, obviously, which we have in a way met in Sweden during the COVID-19 here. And we should really learn from what is happening in the Netherlands now, providing facilities for old people with their individual needs and wishes, that you have this village. Some Swedes say, no, not a segregated village for demented people. But ask the ones who live there, do they like it or not? I mean, we who are healthy and are not in their situation, we believe a number of things. We have myths about their situation and how their life is being led and lived, which isn't true. Ask people. And I think we have to learn from the Netherlands in Sweden to develop a society with a variety of options for demented people in order to a life that make them feel, I'm curious about what is going to happen tomorrow. I think that is important for every old person living in their homes or in care homes, that they should be curious what is going to happen tomorrow, what is in it for me, and not just to say in their prayers, please God, don't let me wake up tomorrow. This is a sentence which I have met too often in care homes, that there is nothing to live with. And this has also been true in this period of isolation due to COVID-19. Then Karin Thalén put up this collaboration, and also Peter with the Norrtälje organization, that we have to collaborate, not work in silos. And in Sweden, we really have to learn from what was said by Karin about Stockholm's sjukhem and from Norrtälje, what you can really, I mean, it will be better for the patients, the older people, it's better for the staff, and it's much better for the economy also if you link care for older people in their homes with primary health care, with the hospital care, and so on. And I wonder really why there are such obstacles against the introduction of this way of organizing care in Sweden. Peter, you might have the answer. And then this with technology. I think Henrik said in the beginning that technology, no, that was not really a solution. I think it's not a solution, but it's one among many solutions. I think that Katarina spelled it out so well about your mother. Ask, what do you need to be able to live an independent life? I mean, I would rather have a robot in the loo in my home than someone I don't know that much about helping me there to make me independent in these very, very personal activities which I need. So I think technology has a future, but it has to be made simple. I've been involved in some projects testing various equipments, and some have been so complicated to use that the users, the older people, put them in their wardrobes, and that listen to what people need, listen what they ask for to be able to use them. So in order to live an independent life. And then figures were shown about the increasing number of older people and the increasing needs. I would very much like a seminar then about how can we make it possible for people to live an independent life as long as possible. Should we prevent falls? How should we prevent a number of things which can handicap older people in order to help them without technology, hopefully, to live an independent life. And I shouldn't use up too much of your time. This was just a kickoff for the debate. Thank you.
Barbro, you are really a star. Such good reflections. Thank you so much. And really talking about being an individual, how important that is. And I noticed that on my mother too. And I was so sad looking at all different things that could have helped her. And I really liked the way you put it, to be curious about tomorrow. So I have also met many people at elderly care homes. They are not curious. They don't have the spirit. So let us all try to work for that. I have one question directly for you, Barbara. And that is, we notice that it is a rapid development of innovation in healthcare, also on the technology side. Why is it so slow when it comes to elderly care?
I think it's age discrimination. Older people are not prioritized in research, in care. Much of it is hidden. People are not aware. It's a lack of awareness of the needs of older people. And I think now when healthcare, hospital care is moving into people's homes, in their flats and so on, I think maybe the interest in developing other technology will increase. And here I think COVID-19 is now helping us to put priorities to these areas.
Thank you, Barbro. Henk, you have been listening also to Barbro's reflections. I don't know if Magnus, if you have a question for Henk, but so far, do you have also some reflections on the discussion?
Yeah, I think one of the big issues is implementation. We have developed a lot of good knowledge and a lot of tools and instruments, etc. And there's so much on the shelf, and we are not using it. And one of the, I saw it in Karen's presentation as well, the COVID-19 crisis gave a huge impact in using technology. But what I see now is that there's a fall back to our old traditions, I would almost say, of going back to the traditional way of working in healthcare and long-term care, etc. But how can we implement? In our country, in the Netherlands, my organization Vilans is now working with organizations in the disability sector in order to learn from each other how to implement technology through their entire organization. So learning from each other is the strategy that we are following, and then learning from peers is the strategy. And so that's one of my puzzles, is why aren't we implementing? I was in Japan last year to look at technology. We got great demonstrations, and then we came in regular nursing homes, and they were working with paper documents, and they did not use the technology. And I was asking, why don't you use it? Well, we don't have the money for it. So I thought, well, but they did have money to use the staff, which could be saved by technology. So there's something strange in the way of we are funding organizations, we are funding home care, etc. So when we are looking at implementation and scaling up, we need to look at skills and capabilities of staff, but also to reinforcements from our systems that we have, our funding systems, etc. And maybe that would be the biggest innovation that we need, is how to implement instead of finding more devices, and that will go on. But if when we really learn the lessons of how can we implement on a large scale, that would contribute. And many things that are mattering to people are not that difficult. There's a lot of technology that you can buy in the stores, in the streets, on internet. That's not sophisticated, but you need to know how you can use it. And that's, I think that would be one of the major concerns for the next time. And it won't be the solution for everything, but it will help a bit. And I think we need to work on various scenarios, various strategies that help a bit in order to deal with the challenges of the future. And reflecting on Barbara, I showed the green farms, and one of the nice things is that people have the feeling there's a reason for me to get up, because I have to go to the farm and take care of the animals. And that's much better than just to play bingo, which is also very nice. I agree with that as well, because you meet other people. But I have to go to the green farm to take care of the animals is a reason to get up in the morning. And we think we should find much more meaningful activities and help to find more meaningful activities. And helping people to live a normal life has become extremely complicated in our healthcare system. We have invented everything which is not normal. And it would help people very much to live a normal life and find something to get up early in the morning. So that's, well, a point that I would like to make. Thank you.
Okay, thank you so much, Henk. Magnus, do we have any comments, questions?
First of all, I have to comment on the last one. I need that for my kids now in November in Sweden, to get up in the morning. That's a hard thing, even if you're a young kid. But let's go to the questions. We should move towards an ecosystem of care. Is it the future model of care in highly developed countries with a population with high educational level? And as a complement to that question, will that lead to unequal elderly care, even though the system seems very good? Yep, it's directed toward you, Henk.
Oh yeah, okay, yeah. I hope it will lead to unequal care, not in the sense that it is not the same solution for everyone, but everyone should have equal access to care. So that is, so I hope there will be diversity, and that we find diverse solutions, because people are different. everyone is a deviation from the average, and I think we should we should not provide average care, but we should give people support which is very tailored. And I think it's I think the development towards ecosystem has a lot to do with being higher educated, being better able to find solutions. There's many patients, clients who are much more or better informed about their disease and about their disability than their doctors are, for instance. And it's not all, and I know there's many who are not, but some of them are, and you can be very well informed. These citizens' initiatives that I talked about, many of these people are highly educated people who can find the solutions, and they connect to people with other skills, who can do transportation, who can do voluntary work, etc., voluntary work. So I think that it is indeed a level of being more educated as a population to find these solutions. And the time that was paternalistic, we had much lower levels of education. So I think we are moving into that direction, unless the dictators will win the battle, but hopefully not.
Hopefully not. I was about to say, let's see tonight. But
this was not a political statement.
Exactly. I'm sorry. The next question is for all of you. Healthcare costs have continued to outpace inflation and just about everything else with the economy. Generally speaking, prices rise when demand increases relative to supply. How could we address this in concrete measures? Just a small question. Whoever likes to take that on.
Well, I think they should start reading Forum for Health Policy's latest report about healthcare after Corona. It will be published in English very soon. But of course, I'm not going to answer that question. Who is ready? Who wants to? Peter?
Yeah, it's an excellent question, actually. The question in one way, I think, summarizes what we're talking about. Regarding these elderly patients, frail elderly, if you wish, or I say complex patients, because it's complex people. I mean, it's many different. I think Karin Thalén showed the one with the picture with it. So we have to realize that if you have complex problems, I was head of the Astrid Lindgren Children's Hospital. They were young, those kids, but they had also complex issues. And we have to treat those patients differently than we do ordinary if we have emergency with heart infarct or something. The complex patients, which we're talking about here, they have to be treated differently. And all the complex patients, I think we all agree on that, have different needs, different issues. The Alaska, I'm a big fan of the Alaska, Douglas Eby, the NUCA system in Alaska, and they have a very nice approach of how they look at their system. It's a consumer-owned system in Alaska and consumer-driven. They do everything that the consumer, the public, the owner of the system, what they want. And they have, after 25 years now, they can show excellent results, much lower costs, better medical outcomes. People are happier, the staffs are happier, etc., etc. So I think there are evidence that if you go about it this way, it's better for everybody. Karin Thalén and myself, Norrtälje and Stockholms sjukhem, we are half the way to the NUCA system in Alaska. We understand, but we're not there. At least I'm not there. And I can see that there are many obstacles in the integrated system where we do the wrong things. For instance, we have now an excellent mobile team from the hospital, Norrtälje Hospital, during the Corona crisis, because the frail elderly, we don't want them to come to the hospital. They don't want to come to the hospital either. So we treat them at their homes. It's much, much cheaper. One nurse and one doctor a little team and a rehab person. They have 20 patients that would, not all of them, but at least some, maybe half of them, would otherwise go to the emergency and come into the hospital. They stay at home, and they are much better there, and they sort of, our beds, our hospital's bed, are gone down because the staff, they are home sick now. So without that mobile team, I don't know how we would survive during the corona crisis. When it comes to the reimbursement system, we don't even know how to measure it, because it's not outside the DRG system and things like that we argue about how could we show that the mobile team is of any impact at all. I mean, and this is the problem. In our elderly homes, we know perfectly well if we put in a floor, the floor goes like this. It's a quite cheap invention from the KTH, Kungliga Tekniska Högskolan. You can put in a floor like that, and if you fall down, you don't break your hips that much. So it's an excellent solution for the elderly in the elderly homes. Who wants to pay for it? The municipality says, we don't have the money, and if you fall and break your hip, the other side gets the benefit. So we do these stupid things all over the place. And Barbara's question, why isn't it implemented? Because we have the silos with the municipalities in Sweden, and we have the regions, healthcare, and different budgets and things like that. So this is for the scientists, Henrik Jordahl and people like that, to figure out how do we make a reimbursement system that sort of does the right things. We haven't talked so much about prevention. Prevention is almost for free. No one pays for it. No one really drives it. I think we should do these things so that the patient won't get sick and go into the hospital and cost a lot of money. So this is sort of the $10 billion question. How do we do this? Thank you.
Okay, thank you, Peter. I don't know if you, perhaps you have more questions, Magnus, or?
Yeah, or if anybody else wants to take on that big $10,000 question.
Yeah, perhaps.
I heard your story and I read the presentation of Karen, etc. And the problem is similar in our country and in a lot of countries. So we think system reforms may change it. They won't change it. In whatever system you have silos. So I don't believe in a world without silos, but the point is, can we make innovations in our funding system so that we get the right money to the right people? So maybe a next seminar should be about innovations in funding, because that gives all wrong types of behavior. And that's one of the things which is bothering me. And the second point is, maybe we are too rich. We can still afford to act in a way in which we are spoiling money and resources and people. And what we saw in this Corona period, COVID period, we saw that lack of staff, etc., and lack of options gave an enormous impetus to using more innovations. And now we are falling back to the time that we have less pressure on the system. So sometimes I think having too much money doesn't make us aware of how we can improve. We are complaining about budget cuts, but that's only slowing down the curve, the Baumol curve, so to speak. But it's not really a budget cut in our country, and also not in other countries. So being a sort of a provocative, I would say maybe we're too rich to really innovate.
Karin, are we too rich to innovate? We may be too rich to innovate.
Peter, you talked about preventions. I think we can use volunteers much more in healthcare and elderly care in Sweden than we do, because we aren't paid for preventions from the region or municipalities. And Peter, earlier you asked, how can we do it better when we started today? And I have two comments. I think we need concepts for how we organize and deliver a seamless healthcare and elderly care. And therefore, the politicians must show courage in decision making. I think it's very important. And the second thing is start with our managers and staffs. Make it exciting to work in healthcare and elderly care, because you must have both managers and staffs who want to work in healthcare and elderly care with energy, desire, and joy. Make it fun. So now, yes, start with the managers and staffs.
So Karin, is that a comment to politicians, or who should do that? Isn't that a responsibility for everybody?
We must do as providers of healthcare, absolutely. Both politicians and who run healthcare must make it more exciting to be in healthcare and elderly care.
Can I comment on that,
Peter?
please? Yes, this is very, very good, Karin, and it's very, very important, I think. During the early phase this spring of the corona crisis, we have never worked so hard in the region. The staff, they worked, every weekend in the beginning. I worked every weekend in the first 10 weeks or so before we got everything running. So, and the ICU units tripled their capacity, things very quickly. But the staff has never been so, how do you say, engaged, and the doctors and the nurses and the leaders, they stepped forward and they really, really, really wanted to solve the problems. And we see that the applications to the nursing school have risen by 30%. Why is that? The politicians, this in Sweden at least, and in Stockholm, this early when the corona started, they stepped back and said, "Hey, you have to do this." So the professionals came forward, and it was really amazing. We worked really hard, but everyone felt now we're doing the right things. The mobile team I was talking about, they are so proud with the mobile team, because they see when we come out to the dementia patients out in the islands, outside the archipelago, we really do the right stuff, and we can prevent with small help, anxiety, things like that. Addressing the right issue, we prevent them from coming into the emergency. Very often they go in, they go back, they go in, they go back without any, So it's really to let the professionals and the leaders, as Karin said, it's really important for them to sort of manage in the right way.
Thank you, Peter. Barbro, you are a politician, so now you speak for all politicians.
Yes, and then it depends on which level you are. I'm a member of parliament, so what I can do is to see how we can put state tax money into the right boxes. And here I think the possibility for healthcare personnel to move on. I mean, if you have very young people who start at the bottom of the old, elderly care, and to be assistant nurses, and from being an assistant nurse to be a nurse, and then from being a nurse to be a specialized nurse, and to get that education with pay from the regions and the municipalities with support of state money. I think that is one of the ways to do it. And especially now when we have many people who lost their jobs and went to the care older people during the COVID-19 pandemic, and then realized that this is a kind of job I want to go on with. So I want to be an assistant nurse and so on. And there we politicians should really then make it possible here with, it's money actually, if you are at this level, then it has to be organized at the regional and municipality level. And then of course, to make people and also journalists sometimes to write the positive things to work with older people. Very often it's the backside of it, the catastrophes and the spread of COVID-19 in homes for older people's care. But also what Peter just said, that it was a challenge to solve these difficult problems. I saw the same thing when my governmental agency, the National Board of Health and Welfare, should have a cut by 1/3 of the staff, and the 2/3 had to cope with all what was being done. And when I asked them, when did you really thrive best in this governmental agency? And it was really when we worked 24 hours a day in order to solve a problem. And then we had a party afterwards. We celebrated. And I think that is very important, that once you have managed to solve the difficult problems, have fun with all the staff. And it doesn't have to be very expensive. You can do very much on your own. What we did was to have a competition in cake baking.
Okay, thank you so much, Barbara. So let me turn to Andrew. Now we're talking about demands for innovation. We need it. We have challenges, we have problems, so we need innovations to actually to answer to fulfill those needs, right? And you gave us lots of examples of different technical stuff. So I was just wondering, also with a connection to that, I think it's much slower development in elderly care when it comes to technological development, even though we have a demand. Barbara was talking about age discrimination. Peter and Henk were talking about funding and so on. What is your view or comment on to speed up innovation in a person-centered way?
So I've been listening to the conversation and looking for the link to innovation. A lot of the conversation, I think, was actually about systemic innovation. If we want to change the way that the funding works and who benefits and who pays and so forth, these are evolved systems, and it doesn't matter how we change them, somebody will lose, and then this will lead to resistance due to this fact. If we introduce technology into the mix, I think that our experience with the internet and everything else has just shown that technology is not a panacea. It does not solve all of our problems. Rather, it accelerates some processes and perhaps slows down others or distracts from them. And this can cause problems. I think that what we need for the innovation, if I go back to a classical role designation, you have the researchers, the engineers, and then you have society at large. Engineers can only solve the problems which have been well posed. Scientists research mostly on what they want to or what they get funded for, which is perhaps not that which is demanded by the society. I think there needs to be a good interaction between the various groups, researching, engineering, and society, in order to properly define what is the problem. We see problems with aging. Age discrimination, for instance, is definitely a problem, but I don't know that we can solve it with technology. it's more of a societal issue. We can provide singular solutions out of the innovation, and then perhaps what we can do is we can look out for possibilities where if we solve a single issue with a technological point of view, this will set free energy to allow other forces to take charge to help things. For instance, Barbara was talking there about how long it takes to become a trained nurse and these sorts of things, how long it takes to do this training and so forth. One technology which you see in industry which is being used is augmented reality, where you get sort of a description. How do you do something? It's just step by step, step by step. I mean, I've seen back in my days when I was in industry, we had demonstrations out of India where you put on one of these augmented reality glasses, you look at an engine, it recognizes the parts and says, turn this screw, replace this part, tuck, 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 step for step. And I think in order to really reduce costs, increase efficiency, if we may take this approach to how we do the care, not in terms of mechanizing things, but in thinking through how it is we want to do things, then perhaps we can use these technologies to speed the rate at which people can be trained, speed the rate at which people can get in there, and also you have a leverage. I think a big difference between my generation and my children's generation is they live in a world where if they want to find out something, they just go to YouTube. And they get it something, and you find everything in YouTube. If it's caring for a baby to breaking into a house, you can find anything in there. And if we can take this in a perhaps more focused way, we say what are the societal problems we need to solve, where we have the highest costs, and where we need to change the skills. We take an approach to using technology to enable people to have those skills. And perhaps we can make a larger difference than if we try and investigate the next fall sensor or the next speaking device or something like this. But I'm involved in a project here in Switzerland at the moment. It's actually about so we've developed some solutions, community solutions, which work in Luzern. You have a critical mass of people and of services which are available. So that means if I develop a platform for enabling people to communicate, elderly people who say, I have a specific need, and then you say to all of the people in the neighborhood, hey, you can log on there and you can help people and so forth. This has a first initial success, and this is good, but it depends on there being enough people. We're now looking, for instance, at translating that into a village, alpine villages. I think you have the same situation in northern Sweden. I don't think it exists in the Dutch environment. It's much too urban. But here in Switzerland, for instance, we have many villages. You have a problem that the young people leave. They go to the city where there are jobs, where there's a bit more life. The youngest people out there are perhaps 56, and we have that problem which was mentioned earlier, that the people who are available to care for the elderly becomes diminishingly small. And the skills which they require become greater and greater. So we're trying to find actually at the moment a way to address this problem with community apps, with other technologies or something like this. But it's, for me, actually, the first problem starts with where do I get the funding? Because without the funding, I don't even start. Yeah. I think the COVID crisis has also shown us necessity is the mother of invention. When we really need to, we can, but it also involves ignoring other things for the short term. If you're working 24 hours a day and on weekends, you can only do this for a certain amount of time before you collapse. So we can really bring this engagement, this motivation for a short amount of time. I think we also need to find a more long-term solution to the innovation problem. If we identify one problem like COVID and we all attack it, then we can really move mountains. But I think that the problem with the situation that we want to increase the quality of life for the elderly is a multifaceted problem, because this is not just one group of people, the elderly. You have many different groups. They are all individuals. They have different needs, and quite often different health needs as well, more diverse than the actual population. And this is what we need to address. A bit of a long-winded answer, I'm afraid.
Thank you, Andrew. Magnus, do we have any questions from our audience?
Of course we have. What challenges do you see between a decentralized healthcare system and user involvement and building intelligence? Would a centralized system perform better, or which parts should be centralized versus decentralized to benefit the user and the patient?
Good
That is a good question.
This is a really so.
Who likes to answer that? Andrew, you seems to be on.
Yeah, it's I seem to be on the spot also because they're asking about building intelligence. I think building intelligence itself, and what we see also in our research as we're moving towards more personalized medicine. This is, I think, supporting the decentralized model. However, also I'm actually an Australian. I come from West Australia, Perth. This is the most isolated city in the world. And I've spoken to doctors and they say they love to work in the hospital in Perth because you know that all problems which happen in a radius of 2,000 kilometers come to you. And you see such a huge variation on different problems and so forth that it's a great place to be. You get a lot of variety. And this is what speaks for centralization. So maybe I dodged the question by saying standard things, decentralize. And all of the new stuff which is popping up along the way, we centralize those as much as possible.
Good. Yeah, Hank.
Yeah, it matters about what is centralized and what is decentralized. The physical contact and the neighborhood, etc. That's something that is really decentralized, of course. When you look at technology, for instance, the infrastructure for technology, that would be very helpful if that could be centralized with possibilities for personalization. So I think that it depends very much on what we are talking about. And when it is about funding, for instance, you need to have national frameworks, but you need to also be aware of different needs in the population, and it should be that. So within the national insurance system or a public funding system, whatever you have, there should be enough room for tailoring on local level, because it really makes, as we have said, it makes a difference whether you're in urban areas or in remote areas or in that makes quite a lot of difference. So I think it should like often it's and is the solution. There should be some centralization, but there should also be very much local freedom and opportunities for tailoring solutions.
Yes. Any of the Swedes would like to answer that question as well, now when we have the other perspectives on the table? Peter?
I think this is an excellent point that Hank is making. Some things I think now is really the time to centralize a lot of things in Sweden, for instance. We have the IT systems, they don't speak to each other. We have 290 municipalities. We have 21 regions. It's way too many in that respect. I would prefer one single, chart, for instance, so that we can communicate over the borders, or systems in Europe talking much better if you refer patients between regions, between countries and things like that. But on the other hand, of course, you have to decentralize things locally. I think is really, really important. We have a different setting in my place in Norrtälje than we have in the northern parts of Sweden and in the Netherlands and things like that. And I think it's really, really important to also emphasize the power that's in every different setting. So I think we need both. Thanks.
So thank you, Peter. I was thinking this perhaps a more overall question to you, Barbro. Being a member of parliament, and you meet a lot of colleagues, politicians on various levels. Do you have lots of discussion in the parliament when it comes to innovation and development in elderly care? Of course, there's a lot of focus now on the COVID, but now when it comes to what we have been discussing today.
It depends on what is a sort of a catastrophe out there, like, this little girl, 3 years old, who died. That causes an immense discussion and involvement and seminars and action. But it seems as if the Standing Committee on Social Matters, where I am, can't have too many balls in the air at the same time. So now very much work has been concentrated partly on COVID-19, partly on what is happening with children who shouldn't stay with their parents, but in other families taking care of them. I think, therefore, COVID-19 gives us now a chance to discuss matters concerning older people more in detail than we have had for years.
Yeah.
So we have to take this chance, and that it's. I mean, take this that we should isolate all 70 plus in this country and making equal between a healthy 70-year-old one with someone 95 years old with complex health situation. That was all wrong and meant, and then, I mean, those fighting COVID-19 didn't see that people isolated get other health problems, like what isolation gives, like depression and cardiac problems and so on. But now they have woken up, and I think this is a very important thing now to catch all these balls in the air about older people and catch them and do something about it.
Thank you so much. And I know that I will work very hard in order to push forward innovation and also new technology, Andrew, in elderly care. And I was always wondering, when my mother was alive, how could I actually help in order to get this iPad or to get this robot or so, but it was very complicated. So we're on our way to wrap up, but I'm going to give you the word, Barbara, very quick.
One thing, this will the quality of life for older people. One thing which doesn't need technical things or anything like that is the presence of animals in care of older people, dogs and cats. And where they have dogs and cats, it makes a very, very much difference, because, as you said, from the Netherlands experience, to go out and take care of the animals. If you have a cat or a dog, you feel needed. It's a very good company to increase life quality for older people who are lonely. Thank you.
Thank you, Barbara. So I think it's time to wrap up. Oh, and before I give the word to Peter, Magnus, perhaps you could just summarize the whole workshop in 1 minute.
Thanks. That's always the funniest task to be given, to summarize a couple of good hours in a couple of sentences. But I will try. We're in the middle of a medical, digital, and organizational revolution, which will affect both care and life of everybody. We really need high-tech labs, but also, and I guess even more, we need implementation. We need the implementation close to the patients. The good thing with COVID-19 is the spotlight on the elderly, the positive spotlight. And we are maybe too rich to innovate. That's the saddest thing today, that rich is a bad thing. But we have unequal care, good unequal care, and that is always better than bad equal care. That is my short summary of today, I guess.
Thank you so much, Magnus, and thank you so much to everybody and also to the audience. Peter, this was a fantastic workshop, I think, discussing different angles on innovation. So some final comments from you?
Yeah, thank you very, very much for your input. And as always, with the Netherlands and with the Swiss and with Forum, I think I learn very much every time. And I thank you all for your contribution. Really, really interesting and challenging and a lot of thoughts. I think Magnus summarized it very, very well. And one final from me also thought is that I think the integration, this one positive aspect is, I find in Norrtälje, for instance, that we come from different backgrounds. And I myself, I come from the university hospital side, from the Karolinska University Hospital. This is where I come from. And we have a couple of people coming from the different institutions like that, coming into the elderly home setting, where frankly the sort of the skills in science and doing research and innovation is traditionally, in Sweden at least, not that high. But I can see that the willingness to learn from my people we have 10 elderly homes is really, really big, and they really want to. So we sort of learn from each other. And also, if you come to the personalized medical side, they are much better in the care side, also omvårdnad in Sweden, than we are, I think, in hospitals. So we can learn very much by integrating. And I think the holistic, I think all of us have said it in different ways, the holistic side of regarding the elderly and the young kids with complex issues. This is the key, actually, where I think innovation and new technologies and things is really, really, really helpful. We did with iPads in the elderly homes. We had medical, when you deliver medications in all our elderly homes and social care now, we have digital solutions where you can sort of distribute medications, really, really successful. And they are so happy that they have it now for patient safety and things like that. So I think we have to continue this. We have to, Katarina, make another workshop very, very soon, discussing this. And I take up, I think it was Hank who said that we have to also make innovation and funding. This is a really, really interesting topic to discuss next time, maybe, because it's really puts the finger on where the problem or very often is. So I think that's a good topic. So thank you very much for participation, and see you soon.
Yeah, since we have 3 minutes, I'm going to steal 1 minute at the end, and just to recommend you all our viewers, to actually go in on our website, Forum for Health Policy, where we today publish a report, Innovation in Elderly Care, and we do it in English, and we have different examples of innovations in various countries. So don't miss it, and we also have other reports there. So please, thank you very much. Magnus, something else? No?
No, nothing more than don't miss the Forum's podcast that is released next week. Maybe the most important thing for next week.
Good.
And in a few days, on Thursday, we will publish a blog article by Andrew Pace, which we will also spread, which we are looking forward to. And we're looking forward to future cooperation with all of you and all the viewers, also to boost innovation and development in elderly care. Thank you so much, everybody.
Thank you. Bye-bye.
Thank you.
So much.